Okay. So, can everybody hear me? Yes. Okay. Let's try to continue. Okay. Right now, we are going to look at the next important topic. Okay. Functional ileus or generalized dynamic ileus. I think we learned about this condition before also. I told you the pathophysiological mechanism as well. And let's try to complete this. Pathophysiology of the generalized dynamic ileus actually consists of, the entire bowel becoming eperistaltic or hypoperistaltic, which means to say the peristaltic movements becomes reduced and at some point of time they become completely paralyzed. So you can also call this kind of condition as the paralytic ileus. All right. Okay. Another name is of generalized dynamic ileus is also paralytic ileus. So what happens in this condition is swallowed air actually dilates and also the fluids fills all lobes of the both small and large intestine. All right. So there will be air dilatation that is entering down from the oropharynx, and then the fluid also fills up the large and small bowel loops. Then, a generalized and dynamic ileus is almost always a result of abdominal or pelvic surgery. Okay, remember this one. A generalized abdominal ileus, okay, or a paralytic ileus is a resultant of previous abdominal surgeries or pelvic surgeries, and in which the bowel is actually manipulated during the surgery. Manipulation is actually a term that is actually used in surgery, which means to say, most of the times, any kind of a person with an unexplained abdominal pain or an abdominal symptoms, okay, chronic abdominal symptoms, generally they will be indicated up uh, with an open laparotomy procedure, okay, any kind of a person with not all the patients, okay, most of the patients will be, unexplained abdominal pain or unexplained abdominal symptoms for a chronic time is actually going to, indicate for the abdominal laparotomy, so open abdominal surgery. At that point of time, what actually manipulation in the sense is that you are going to search for it. You are going to pull out all the intestines and then you are going to search what exactly or where exactly the problem is. So that is actually called as manipulation. Okay, manual handling of the intestines is called as manipulation. So, and which actually happens during abdominal surgeries or pelvic surgeries. Most important pelvic surgery that we actually know of is a C-section. Okay, cesarean section that is actually done for the extraction of the fetus through abdomen is actually called as a cesarean section. Okay, or sometimes you can also do the cholecystitis, open cholecystitis surgeries, or when you are trying to do the Billroth 1, Billroth 2 types of surgeries. Okay, you heard these names, right? Uh, Billroth surgeries, okay, Billroth 1 and Billroth 2. Did you hear these terms before? Billroth 1, Billroth 2, okay, heard these terms? Okay, okay, remember, this is actually, these type of surgeries, you will learn them in surgery as well. Billroth 1 and Billroth 2 are the types of surgeries where there will be, anastomosis of the jejunum and the stomach. Okay, in case of pyloric stenosis, you will be performing anastomosis. You are going to remove a segment wherever the defective segment of the duodenum or the jejunum is present, which is going to be anastomosed directly to the stomach or the intestine. So that is one Billroth 1 and Billroth 2 types of surgeries. Just be familiar with these terms. These are the types of abdominal surgeries. And acute cholecystitis, you are going to open up the abdomen. There are two types of approaches. One is a laparoscopic approach of extraction of the cholecystitis patient, extraction of the gallbladder through laparoscopy, or also, if in case of severe bile duct obstructions, common bile duct stones, which is actually called as choledecholithiasis. Okay, heard this name? Choledecholithiasis. Have you heard this term before? Choledecholithiasis, stones that are present down in the common bile duct. Okay, stones might be present down in the gallbladder, which is actually called as cholelithiasis. But if the stones are present down in the common bile duct, you actually call this condition as choledecholithiasis. Okay, cholecystitis. Cholecystitis is inflammation of the gallbladder. Stones that are present inside the gallbladder is called as cholelithiasis. Stones present in the common bile duct is actually called as choledecholithiasis. Okay, so this one actually either you can go with the approach of laparoscopy, but sometimes if there is obstruction that is present down in the common bile duct, depending upon the number of stones, you actually may also prefer to open up the abdomen and then manipulate for the extraction of the gallbladder. So such is actually called as manipulation. Handling of the intestines by the doctor is actually called as manipulations, or you are going to search what is the problem that is present down in the bowel loops is also called as manipulations. It is most commonly present down generally during cesarean section. Yeah, it may not happen, but one of the reasons pelvic surgery is cesarean section. Okay, and then what are the imaging findings we actually see here? That you have to understand that the here the whole part of the abdomen became paralyzed. All the bowel loops became paralyzed, and the entire loops of the bowel are actually becoming air contained and abnormally dilated. Okay, and they both the large bowel and the small bowel will actually become completely dilated and become filled up with the air, and the stomach is also dilated as well. So the absence of the peristaltic movement and the continued production of the intestinal secretions usually produces many long air fluid levels in the bowel. So you have to understand that bigger air fluid levels that are present down in the abdomen, okay, is the main important characteristic radiographic feature of a generalized adynamic ileus. Okay, and the other thing is that again the same kind of a problem comes here. Okay, what happens if there is a mechanical kind of obstruction present in these patients? How can we actually differentiate them? So that is the biggest differentiating pitfall that you actually face here. So what actually is, if there is no mechanical obstruction, okay, there should be gas that is present down in the rectum and sigmoid, which is quite simple, like what we understood before. Also, the air should always be present down in the rectum and sigmoid. Okay, if the air is present down in the rectum and sigmoid, we are going to make our diagnosis two words: a paralytic ileus, okay, generalized dynamic ileus, or if it is only a single segment that has been involved, we are going to call it as a localized sentinel loop. Simple, that is what the differentiation is. Okay, and then the vowel sounds are frequently absent or hypoactive. So can somebody tell me what is the technical name for the abdominal sounds? I mentioned this before. What are the sounds of abdomen called as? What is the scientific term for abdominal sounds? Anybody? Yes, borborygmi. Borborygmi are the technical terms for abdominal sounds. Okay, since we are talking about the sounds, can somebody tell me what are the sounds that are heard during a stethoscope when you are looking for blood pressure? What is the term for sounds that are heard during the blood pressure? Okay, you are going to put your stethoscope along the cubital fossa, and then you are going to look for you are going to hear for the sounds of the arteries, right? So what is that kind of sound that is actually called when you are auscultating on the chest? You actually called as the, okay, aortic valve sound, pulmonary valve sound. Yes, they are called as the Korotkov sounds. Perfect. Okay, don't ever try to forget these terms, Borborygmi or Korotkov sounds, because you are going to write down in your case sheets, okay, what are these sounds and how many sounds are heard per minute. Okay, that is the basic important finding that you are going to write down in your prescription. All right. So, but here, what actually happens is that when you are trying to put down this stethoscope on the abdomen and trying to hear for the vowel sounds or borborygmi, you are going to hear very less. Okay, can somebody tell me what is the normal value of the vowel sounds? How many vowel sounds per minute is considered to be normal? When you put the stethoscope on the abdomen for a minute and try to hear the sounds, how many sounds per minute is considered to be normal? Okay, generally, yes, 1 to 3 per 60 seconds. Yes, it is technically considered to be normal, but the maximum range is something around like 2 to 6, okay, or 4 to 6. Also, you can particularly say it, okay. So generally, 1 to 6 sounds per a minute is actually the normal value of barborygmi. But when you have to make sure that you are listening very carefully because these are very faint sounds. Most of the doctors will not be able to interpret these sounds. Okay, so try when you are trying to learn physical examination, try to understand what exactly is the pattern of the borborygmi. Okay, but you need just practice because that may be difficult sometimes, because that is the one of the most important clinical finding when you are trying to diagnose a generalized dynamic ileus. All right. So how does the radiograph look like? Look at this very carefully here. When you are trying to look at, there are abnormally dilated bowel loops all over the abdomen. Look, a lot of air that is present down, hyperlucent bowel loops that are present all over the abdomen, extending without any particular region. Okay. Now, before in sentinel loop, where we came to find out that the extension is happening from one side to the other side. In pancreatic condition, we came to understand that they happen from the uh, hypochondriac region to the right iliac region. So that is how they are extending. But here in this picture, you can see here a lot of abnormally dilated bowel loops all over the abdomen. Okay, they are radiolucent. And then you can see here the air is also present down inside the rectum as well. Okay, right? Air is present inside the rectum. Okay, and then you are going to see these small intestinal arrows. Here is this one, and then the large intestinal arrows are this one. So all the in the lumbar regions, okay, these are the large intestinal shadows, and in the central region you are going to look at down the small intestinal regions. So intestine, small intestine is dilated, large intestine is dilated, and air is present down inside the rectum. Okay, supine position and upright position, both the images are taken and considered. When we are looking at this one, you see here the abnormally presented dilated bowel loops all over the abdomen. Okay, is actually suggesting us that we are looking indeed at a case of generalized dynamic ileus. Okay, and the observation made by the doctor, a clinical physician, is actually the patient has no borborygmi, okay, and has undergone a colon surgery a day before. So remember, this kind of a generalized dynamic ileus will be coming down as an acute complication that is related down to the abdominal surgeries. Previous abdominal surgery, okay, it is not a chronic condition. Remember, this is actually an acute condition which is immediately shown down within 24 hours of abdominal surgery history. Get it? So that is how we are going to differentiate it from the large bowel obstruction or small bowel obstruction, which is a chronic condition. Even they have abdominal surgery manipulation there, but still they happen after 1 week or chronically in those patients where the complete mechanical obstruction is happening. But in generalized dynamic ileus, it is going to happen as an acute condition within a day or two. All right. Now, we are going to actually, the patients that are presenting down with the generalized dynamic ileus, they do not present to the emergency department because there will be, a persistent abdominal bloating, which is constant, okay, persistent abdominal bloating, and then they are generally only 1 or 2 days post-operative people, okay, abdominal surgery, gynecologic surgery, the most important and the frequent gynecological surgery we are looking in a hospital is hysterectomy or cesarean sections. Okay, hysterectomy, I think you know what is hysterectomy. Yes or no? Gynecologic surgery, hysterectomy, and C-section. Okay, hysterectomy is a surgical procedure to remove out the uterus due to clinical conditions like uterine fibroids, okay, or uterine cancers. Okay, endometriosis, pelvic inflammatory diseases. Okay, uterine fibroids are the ones that are actually, uh, you know, uh, performed for gynecological purposes. And cesarean section manipulation, okay, is also generally done uh, for the extraction of the fetus through abdomen. Okay, normal vaginal delivery is the extraction of the fetus from the vaginal orifice or the cervical orifice, but cesarean section is the extraction of the fetus from the abdomen. So these two famous gynecological surgeries, hysterectomy and cesarean section, yes, in such kind of patients, you can actually be looking at a generalized dynamic ileus. And also, you are going to look at a severe electrolyte imbalance, which is hypokalemia. Okay. Yeah. Well, yes, Benedict, we are going to talk about the dynamic ileus and volvulus. Last part of this chapter is about volvulus, but you are going to look at volvulus as a particular radiographic sign that is actually called as coffee bean sign. Okay, coffee bean sign. Okay, that is what is present down in a volvulus patient. Okay, coffee bean sign, and only a single part of the that loop is going to appear down like a coffee bean, a very big coffee bean that is present all over the abdomen. Okay, that is how we are going to differentiate it. Okay, we will look in a short while. Okay, that is how we are going to differentiate. But here you have to understand here one thing, that in a dynamic ileus, that everything will be the air, the hyperlucent, bowel loops are present all over the abdomen. But in volvulus, it doesn't look like that way. It is a single bowel loop that has been extending all over the abdomen. Okay, you will. I will when I show you the image of a copy bean sign, you will be able to understand it. All right, don't worry. We will cover that part. Last time I was telling you that the patients will also be suffering from hypokalemia, right? Uh, the reason, I think I explained the pathophysiological mechanism behind this electrolyte imbalance, but understand hypokalemia in these patients will be frequently seen. All right. Now we are going to get down into the most important topics of this chapter. Okay. Uh, Expect an essay question from these parts. Okay. Mechanical small bowel obstruction, large bowel obstruction, and volvulus. You will be having an essay question from this. Okay. So make sure that you are going to lead these chapters very well. Okay. And essay question, important case studies will be coming down from this one. You will be able to familiarize yourself with the generalized conventional radiography features along with CT scan observations. Okay, so it is a little bit difficult, but still I'll try to complete it. By this time, you are already familiar about the pathophysiological mechanism behind it. But let me recall once again so that you can have a better understanding now. Okay, so a mechanical small bowel obstruction, you have to make understand here one thing, that this is a true obstruction of the bowel lumen. Okay, so it happens as a lesion is present inside or outside the small bowel and obstructing the lumen. Okay, if it is present inside the lumen, it is an active obstruction. It is present outside the lumen, it will be a counteractive obstruction. Okay, and then what happens is that over time, from the point of obstruction backward, okay, remember carefully, here from the point of obstruction backward in the sense that you are moving proximally, okay, you are moving proximally above the obstruction level, the small bowel dilatates and continuously happening because of the swallowed air and the intestinal fluid that is continuously being filled up by the stomach and the pancreas and the biliary system and the small bowel. Okay, remember, a abnormal dilatation of the proximal bowel loop indicates that there is a small bowel obstruction. It can be happening because of the obstruction that is present inside or outside of the small bowel, counteractively or actively obstructing the lumen. Okay, is this clear? Yes. Please let me know if you are clear or not. Okay, so here you always have to go backward in the sense you are moving above, you are moving proximally, and you are the radiographic sign that you are going to look at is the proximal bowel dilatation. It is happening because of continuous filling of the air that is being swallowed and also the intestinal fluid that is released by the stomach, pancreas, and the biliary system and the small bowel. Okay, so that is the one that is showing up deep dilatations. Okay, and Peristalsis actually happens in these patients, continues and increase over time in an effort to overcome the obstruction. So the abdominal pain that is happening here is because of the obstruction, but the barborhythmy sounds that you are going to listen up, increased barborhythmy sounds over time that you are going to listen is actually in an attempt to overcome the obstruction. So that is different and this is different. You see here before patients there is no peristaltic movement, but here the peristaltic movement is present and it is actually a defensive mechanism that is acquired by the intestines in an attempt to remove the obstruction. Okay, they are trying to accumulate the open spaces down in the abdomen so that they can freely move. So that's the reason they are continuously moving and there is a continuous peristaltic movement. So how do you recognize these borborygmi here? They are high pitched sounds and they is indicating the hyperactive vowel sounds. Okay, high pitched sounds. Where the borborygmi are generally low pitched sounds and very vague or faint sounds that are coming down on the abdomen. Okay, something like a small crackling sensation that is coming down in the abdomen. But uh, as the time passes, what actually happens is that the peristaltic waves try to empty the small bowel along with the colon for their contents and from the point of obstruction toward the next point of obstruction. Next point of the loop. So here the mechanism is actually happening that there is a point of obstruction, and now what actually happens is that these peristaltic waves are moving distally. Okay, the contents of the abdomen are moved distally. So if there is a content that is present down in the abdomen, what happens? It becomes hyperdense. Okay, so do you want me to explain in a diagrammatic way, or were you able to follow it? If you are able to follow it, okay, well, we will not be dealing it completely, I mean to say in pretty much active images, because while we are looking at the radiographic images, yes, you will be able to understand it. Diagram, okay, fine. Then let me get the diagrams for you. Like what we did yesterday, let me check it out. Give me a minute. Okay. Anybody? All people were able to look at the blackboard, right? Okay. You see here. Let's say the large bubble that is present down here, like this. Okay. And then the small intestine that is present down here, something like this. Okay. Let's take it not to scale, not exact, but still let us try to understand. Let us say here the air has been coming down from above, right? This is the first thing. Let us say there is an obstruction that is present down here. Okay. Now, what actually happens is that the air has been coming down, and here is the gallbladder. Okay, here is the pancreas. Okay, and then here is the stomach. All these things will start to give up the fluids, right? And the fluid starts to enter, and air is entering. So, what actually happens is that this one becomes much more dilated, like this. Okay, and then the peristaltic movement is happening here. First thing, the peristaltic movement happens here. Now, in an attempt to move this obstruction to the next level, what they are happening, the peristaltic movement actually takes place. So here, whatever the abdominal contents that are present down here will be moving down slowly like this, like this, right? So they become much more hyperdense. The all other parts becomes much more hyperdense. Okay, very, not exactly like a net, but what actually happens is that they become much more hyperdense. So there is an abnormal dilatation above in the proximal region, and in the distal region, you will be having a hyperdense structure. So in an attempt of the peristaltic movements. So that is how you are going to look at it. And there will be, okay, since there are so many loops, what you are actually going to see is that there are something like abnormal levels of the dilatation in the proximal region. Okay, this is proximally, and in the distally, you will be having a hypertense area. So that is how it is going to look down. Okay, multiple air fluid levels. Okay, since the continuation is like this. Okay, so that's the reason you are going to, and this is the part of obstruction. Understand? Okay, yes, the fluids are going to fill up here. Okay, fluid is going to fill up here. Air is above, fluid is below. Okay, so it is going to show multiple air fluid levels. Is this clear now? Yes? Please let me know if you understood it. Yes? Okay, right? So let us try to look at some now, and we will try to understand. And you also have to understand here one thing, since the contents are going down distally, what actually happens is that, okay, if there is enough time has elapsed, the onset of symptoms, what actually does is that there is no air that is present down in the rectum or the sigmoid. Okay, and let us try to learn some causes here. I'm not going to details of the pathophysiological mechanism of these causes here, but still you have to by heart these names. Okay, the first important reason is the post-surgical adhesions. Okay, post-surgical adhesion is something like this. Okay, uh, when you are, let us say, you are looking at, see, let's say this is the abdomen. Okay, and right now I have opened up the abdomen like this from the central region. Okay, I have opened it. Okay, I have opened it, and as this one part, and I have this one. This is one flap, and this is one flap. Okay, abdomen. Okay, this is the abdomen. Now, when I opened it like a book, okay, when I opened it like a book, okay, there is a flap that is present down here, and there is a flap that is present down here. Now the intestinal contents are being visualized. Okay, now what actually happens in during adhesions is that, okay, let us say there is an uterus that is present here. I'm taking down a classical example, okay, of hysterectomy. All right, so what I did is that I am trying to remove off the uterus. Okay, first I'm going to try to remove off the uterus. Now let me draw this diagram in a separate view, in a different view. Okay, I'm going to look it in the lateral sides like this. Okay, what is the position of the uterus? Okay, let us say this is the uterus. Okay, this is the urinary bladder. Okay, and there is the uterus that is present down and inverted in position over the urinary bladder, right? Yes or no? Okay, this is the uterus and this is the bladder, urinary bladder. All right, so it is present down as an antiverted position along the uterus. Now, the intestines are present somewhere along like this. Okay, this is the large bowel, and the rectum is coming down like this. Okay, the rectum is coming down like this. Okay, this is the rectum. Okay, this is the colon. Okay, and this is the rectum, right? Now here there is a small intestine that is present down like this. Okay, some bowel loop like this, that is the small intestine. Okay, this is the small intestine. So this became the large intestine or colon, and this became the small intestine. Is this clear, at least for now? Yes? Yes, no? Okay. Now, in the process of surgery, what I'm going to do is that I'm going to remove of this uterus. Okay, that is what actually called as hysterectomy. Okay, you need not learn about the complete process of hysterectomy, but still understand that there are two types of hysterectomy. One is the vaginal hysterectomy, okay, which you are going to partial hysterectomy or complete hysterectomy, okay, where the cervix is spared. Okay, this is the cervix of the uterus. Okay, this is the uterus. Let's say uterus has got the cervix, uterine cervix. Okay, uterine cervix, and this is the vaginal orifice. Okay, what actually they do in hysterectomy is that, okay, this is a hysterectomy uterus. What actually they do is that either they remove the uterus until here, this part, or they're going to remove as a whole part like this. Okay, it can be done either through vaginal place, vaginal interface, or you can actually be going down from the abdominal incision. There's about this level, and then you are going to extract it. But right now, when I removed of the uterus, actually what happens is that, again, when we are looking in a different view, what actually happens here is the colon is present again here. Okay, colon is present here, and rectum is present here, small intestine is present here, and right now this urinary bladder is present here, and there is no uterus. Yes or no? Because I removed it. Now, before, what actually happens is that there are present down the fascia that is present down as the separation of these contents here. Okay, a fascia that is present down here, a fascia that is present down here, which is actually separating all the contents of the abdomen, right? If you know about the pelvic floor, okay, have you heard these terms before? Or perineum? Have you heard this term called as perineum? Yes, perineum, pelvic floor. Do you know about the pelvic floor anatomy? If not, better go back and again read the floor of the perineum. Pelvic floor is a very, very important topic. In all competitive exams, a lot of questions will be coming down from the perineum. Okay, floor of the pelvis. Okay, so try to learn that one, but I'm not going to get into that detail here. What actually happens here that right now the uterus is not present. So what actually happens is that these fascias, where they actually start to understand that the organ is absent here, and they are going to make up connections with each other. What happens is that they start to make up connections with each other, so which actually restricts the movement. So these kind of connections that are actually made by the abdomen after abdominal surgery are actually called as adhesions. Adhesions or adhesions, okay, they are going to, you know, make connections between all the structures. So that why when they will be restricting up movement, so they will be, you know, making connections with all other fascias in and around them, and they are going to restrict the movement of this small intestine, or they are going to restrict the movement of this colon, sigmoid colon, or rectum. Understand? Is this clear now? Yes. Okay, while after I remove an organ from a part, from the abdomen, what actually happens is that they are going to make connections with each other, because the body was able to recognize that the space has been gone. Okay, any kind of a space that is an open space that is present inside the abdomen, what actually happens is that the abdomen is going to take up that space. Okay, generally, you know, the each of the floor of the perineum or the perineal layers that are present down, they have got their own fascia that are present above them. Okay, and right now that fascia has been gone, so what actually happens is that they are going to form abnormal connections in between them. So because of this process, what actually, because these adhesions or abnormal connections have been developed, so what actually the surgeons came to understand is that, okay, still the body should not be able to recognize this space, and the intestine should not take up these contents. So what actually happens is that they are going to spare some of the organs and actually also try not to remove those fascias during the procedure, so that uterus lies in the uterine area itself, urinary bladder lies in the same area itself, and intestines try to lie down in the same area itself, so that no abnormal connections will be formed. So newer surgical techniques have evolved, and such kind of surgical procedures sparing down the organs, sparing in the sense I'm not completely removing every anatomical connection related down to that structure which I'm trying to remove. So I am going to leave off some things, okay, something like anatomical fascias and musculature that might be related down to them, and I'm also adequately trying to also ligate the abdominal blood vessels and try to compensate the space that is present. Actually, it can be called as padding. Okay, it is called as padding. Padding in the sense is that what you actually do during the padding is that you are going to fill up the space with some kind of a, absorbable content in the abdomen, so that the adhesions do not actually happen, so that it actually fills out the space that is present down at that region. And generally the body is not going to recognize if the argon has gone. So when you are trying to do padding, or when you are trying to spare the organs, okay, spare certain parts of the organs, what actually happens is that the body will not recognize that the empty space is present. So when there is no empty space is present and it is not recognized the body, what actually happens is that these adhesions are prevented. So newer surgical methods actually have taken down of development of these post-surgical adhesions. But one thing you have to understand here is that these are inevitable. Okay, every time this touch of surgical detail may not be taken down in most of the situations. So like following the surgeries like appendectomy is a faint organ. It is something like a finger-like projection, which is something around like 2 to 3 centimeters. And colorectal surgery, we are going to remove the part of colon. Okay, colectomy we call it as. Okay, pelvic surgery generally for the pelvic inflammatory diseases, or you are going to do the transition point of the small bowel CT without other identifying cause. So generally, what we actually see here is that the post-surgical adhesions actually causes the transition point, okay, that they change in their position, and it is observed on the CT, and there will be no underlying cause. Okay, what is the only cause that is present down here is only the surgery, previous history of surgery. So that is the reason why we are including the surgical history in while we are tracking down when we are consulting a patient. Okay, then the next important condition is malignancy. Primary malignancy is actually the one that is actually present inside the bowel, or sometimes outside the bowel also. Okay, there are so many conditions where there are some gastric. Sorry, not gastric tumors. Actually, intestinal tumors that might be present, or an abnormal kidney uh, tumor that might be present, or pancreatic cancers, all those things. Okay, secondary tumors either present down in the small bowel, inside or outside. So malignancy will be present, and these kind of malignancies generally will be given a palpable abdominal mass. Okay, a feeling of palpable abdominal mass in during physical examination. So on physical examination, if you are suspecting that there is a palpable abdominal mass, you are going to do a physical examination technique that is actually called as bellotment. Okay, have you heard this term that is called as bellotment? Right? Yes, yes or no? Bellotment. Okay, maybe in physical examination diagnostic classes you will be hearing this term, which is actually called as bellotment. Bellotment is a thing that is actually whenever there is a mass that is present inside the abdomen, okay, be it inside the intestine or being outside of the other abdominal organs like kidneys or spleen, liver, or something like that. Okay, what we actually try to do is that we are going to check for the mobility of these contents. Okay, development is a palpable diagnostic method. What we actually do is that see the mobility of the kidneys. Okay, to actually palpate the kidneys, we are going to use a diagnostic palpation procedure that is called as ballotment. This can also be used for abdominal masses as well, and we are going to check for the motility of these these masses. Okay, motile, non-motile mass, or motility of abdominal contents. Okay, that is what ballotment is: motility of abdominal contents, abdominal organs particularly. Okay, that is called as ballotment. This is a palpation procedure. So when you are trying to touch the abdomen, what we are going to see is that, okay, let us say if there is a bigger mass that is present. Now you will actually try to see if the mass is moving from one side to other side or not. Okay, if it is moving, you mean to say that the ballotment is positive. Okay, that is also happening with the kidney itself. Okay, so generally we use ballotment palpation procedure for the kidneys, palpation of the kidneys, but it can also be applicable for abdominal masses as well. So you can say that if the mass is moving, you call it as a motile mass, or if the mass is not moving, you call it as a non-motile mass. Okay, so when you actually do this kind of thing, actually you can see that the secondary tumors diagnosis can be made, and as the gastric cancers or the colonic carcinomas or the ovarian cancers may actually compromise the lumen of the small bowel. Okay, let me interpret that one, how actually they happen. Let us take again the same classical example of uterus itself. Okay, now I think you heard about a condition that is actually called as leiomyoma. Yes or no? Have you heard of this condition, leiomyoma? Okay, what is the classical name for that condition? Colloquial name, non-scientific name? Okay, uterine fibroids. Perfect. So you see here, there are so many types of uterine fibroids. What we actually see here, okay, let us say this is the uterus. Okay, uterus, and uterus has got fibroids. Okay, there are three layers of the uterus. What we actually see is that they can be happening down in the mucosa. Okay, let us say this is the uterus cavity. Okay, a mass can happen inside the uterine cavity. A mass can be happening within the mucosal layer. A mass can be happening in the muscular layer. Yes. While you are learning pathology, I think the teacher has actually introduced you. There are three types of leiomyomas. Okay, it might be happening from the endometrial layer, which is actually called as endometrial fibroid. Okay, it can be happening down within the mucosa and submucosa. It is actually called as mucosal leiomyoma. If it is happening along the muscular layer, it is actually called as the muscular leiomyoma. Right? Leiomyoma is generally the one that is actually called as the uterine fibroids. Now you see here, as the uterus is a very very small organ, okay, which is present something around like 5 to 10 centimeters. Okay, unless it is pregnancy. Okay, remember, you can't misdiagnose a pregnancy as a uterine leiomyoma. Okay, so do not forget this condition. Pregnancy also increases the uterine cavity, right? If there is a fetus that is present down, what actually happens is that it is actually present down in the uterine cavity like this, and the fetus is developing like this. Okay, so if it is developing like this, what actually happens is that the uterine cavity keeps on expanding. The same way happens as these masses become bigger and bigger and bigger, or this one are becoming bigger and bigger and bigger. The same way these are getting bigger and bigger and bigger. What actually happens is that the intestines that are present around this place are counteractively obstructed. Yes or no? Let us say this continuation one loop here and this one loop here. So this part is actually being obstructed. right? Because of the counteractive pressure that is going down into this area. So that one is actually going to cause, okay, that one is actually going to cause the obstruction. Did you get it? Right? Ovarian cancers, generally ovarian cancers, okay, let us say here ovary is also present, okay, ovarian cancers, they become bigger and bigger and bigger, okay, or a condition like ectopic pregnancy, which is happening down in the fallopian tubules, okay, this one is also going to cause such kind of condition. So all of these things are going to cause. Most important common conditions are, uterine fibroids and the ovarian cancers, okay. Then there is another condition that is actually called as the hernia. Okay, have you heard of this term that is called as hernia? Yes, hernia. Okay, there are two types of hernia. One is a femoral hernia. Okay, femoral hernia, and other is called as inguinal hernia. Okay, inguinal hernia. Okay, the condition is inguinal hernia can further be classified down into two types, which is actually called as indirect hernia and direct hernia. Okay, indirect hernia and direct hernia. You will be learning about this again in surgery in much more pretty good detail. But this one you have to understand that hernia is an invagination of the abdominal contents through the superior inguinal ring or the inferior inguinal ring. You know this anatomy, I guess? Superior inguinal ring or the inferior inguinal ring. Yes, right? Okay, the abdomen, let us say this is the inguinal ring. Okay, what actually happens is that there is a small intestine that is passing down above from here. What actually happens is that since they found out this place here, what we actually happens is that they try to get down through this ring and get stuck down here. Okay, that is actually called as inguinal hernia. So in inguinal hernia, what actually happens is that there is an invagination of the intestinal loop from the inguinal ring. Okay, generally if it is happening from the directly from the inguinal ring, it is actually called as a direct hernia. But it is happening from above, say outside of the inguinal ring, it is called as an indirect hernia. It is going down into the scrotal sac that is present down here. Okay, so such kind of thing is actually called as inguinal hernia, which is commonly present down in males. Okay, but there is no a complete inguinal ring, and the inferior inguinal ring is only present down in the females in the perineum. So where actually that one is actually called as a femoral ring or the femoral, and if the intestine is actually being invaginated from that place is actually called as a femoral hernia. Okay, so this is actually a form of indirect hernia itself. So if it is actually happening from the femoral ring, we call it as femoral hernia, and this is most common in females. Okay, this is most common in females. Okay, you will learn about these details again later on, but still you have to understand why I actually tell you here is that the diagnosis is different. Okay, femoral hernia is a different condition which is happening only in females, and inguinal hernia is a condition that is actually happening in males. So the contents and the contents are actually, the intestinal loop is actually going down into the scrotal sac. Okay, a testicular sac, that is the one that is actually accumulating this intestinal loop, and in females actually happening, and they will be accumulated down within the thigh or the pelvic region. So the diagnosis, the radiographic area that you are looking at is entirely different. So that's the reason you have to make yourself sure about the floor of the perineum and perineal anatomy. That's the reason it is very, very important. Okay, if you did not learn about that, please learn it again and again. Okay, go back to your anatomical book and learn about the perineum, pelvic region. Okay, pelvis is a very, very important anatomical region. You have to make yourself this. A lot of clinical conditions come in this place. Okay, malignancies, Yes, they cause intestinal obstruction, hernia. Yes, they cause it. Okay, now look at here. Can somebody tell me if this is a male or a female? While you are looking at this image, can you tell me if it is a male or a female? It's a male. Okay, right now, let me give you a clue. Do we actually know it's a male or a female? Benedict, can you answer this question? Jabalina, can you answer this question? How do we differentiate if it is a male or a female? What is the most important thing that we are actually differentiating from male from a female? The pelvic girdle? Okay, not exactly. Diameter? Not exactly. Not completely yet. Okay, but it's fine. Yes, pelvic girdle. I'm going to look at the pelvic girdle one. Okay. If not pelvic girdle, how I'm going to look at it? Okay. For example, let me give you a very simple question. When a baby is born, how do you know if it's a male or a female? You are going to look at the genital organs, right? External genitalia. When you are going to evaluate for the external genitalia, you will be knowing if it is a male or a female. And other things, when you are trying to look in the anatomy, deep inside the anatomy, you understand that the ureter, okay, the ureter of the males is longer, okay, pelvic urethra is longer, and the female urethra is shorter. Yes or no? Do you know this? A simple anatomical calculation, right? Okay, male urethra is continued down as the, bladder urethra and the prostatic urethra and the penile urethra. Yes or no? Where this one is not differentiated down in females, okay? And you are going to look at that one. When you look at this radiograph, particularly, you can actually see that the loop is in a S shape, where it is differentiating that the bladder urethra, prostatic urethra, where it actually takes down a bend after the prostatic urethra, it is going to take down a bend and continue down through the penis, and it is going to show down as the penile urethra. So three parts of urethra is familiar here. So that's how I came to know that this is a male. Generally, you see here on this external radiograph. Okay, okay. Let me explain that one. Let me see. Uh, okay, let us say this is the urinary bladder. Okay, and then the it is coming down as the urethra, right? So when you actually go down, there is this the bladder urethra part, first part of the urethra, and then here is a prostate gland, and it is passing in between the prostatic gland, so you call it as the prostatic urethra, prostate gland. Okay, this is the prostatic urethra, and then when it is moving down, it is going to take a curve, okay, a simple curve, and getting down into the penis. Okay, it is getting down into the penis, right, which is actually called as the penile urethra. Okay, and this is a classical feature of males. Yes, clear? Reshma, is it clear? Okay, bladder urethra, prostatic urethra, and penile urethra are the three parts of the male urethra. Okay, so now what actually I saw there in that image is the Foley's catheter that is being inserted and taking out turns like this, and it is getting down here. And it actually suggests me that I might be looking down at a male organ. Because in a female, what actually happens is that, okay, let us say this is the uterus here, Okay, this is the uterus, and this is the cervical opening, and this is the vaginal orifice. Okay, and where there will be vaginal orifice, so what I'm going to do is that when I'm trying to look it from the floor of the vagina, something like this, when I actually ask the patient to sit down in a lithotomy position, I'm going to look down as two openings, okay, which is the vaginal orifice that is present like this, okay, and then here I'm going to look at the urethra, female urethral opening. Okay, so this is actually the urethral orifice. Okay, urethral orifice. Okay, and this is the vaginal opening, right? This is the vaginal opening, right? So when I'm looking in a cross section from a side view, actually it looks something like this. So it is the urinary bladder, and the urethra is just something like this, and it is opening. So this is already the vaginal opening here, right? So the external genitalia, actually the women does not have any external genitalia like the penis, which is actually hanging out from a male pelvis. But in the females, it is actually not like this, right? So this is actually when I'm trying to look from the inferior, look when the patient is actually squatting, okay? This is the way how it actually looks down. And in this one, you can see here, this the female urethra is shorter, okay, and if the female urethra is shorter, when I'm trying to insert a Foley's catheter, I will be seeing a shorter urethra. That's it. I won't be seeing all these curves. Okay, that is how I'm going to differentiate on a radiographic if I'm looking at a male person or I'm looking at a female person. Did you understand this? Yes. Okay, right. uh, try to learn this one because it might be pretty useful. Because if you are trying to diagnose a condition called as inguinal hernia, you cannot be talking about a femoral hernia in a case of a male patient, because there is no femoral ring. They will be having inguinal ring, which is differentiated down as the direct and indirect inguinal rings, okay, superior and inferior, where the superior is absent, superior is present down in the males, and the inferior is absent in the female. So that's the reason you are going to differentiate it. Okay, so you cannot make a long diagnosis there, and you cannot say that I haven't seen a uterus in this pelvis. Of course, if you did not see uterus in that pelvis, of course you are looking at a male patient. Then you have to look for the penis and check for, okay, if you are confirming down if you are looking at a male patient or not. Understand? Because such kind of mistakes actually happened. I'm telling you this way because, okay, once when I was practicing in a village clinic, what actually happens is that I have sent a male patient for an ultrasound, and you know, the doctor has actually written down the ultrasound report saying that uterus is not visualized. Okay, fair enough. If uterus is not visualized, yes, maybe hysterectomy could have happened in that patient, right? But no, I have sent a male patient. How? Of course, uterus will not be visualized. Yes or no? So please do not make such kind of very very simple mistakes when it comes down to determining the sex of a person. It's the easiest way to recognize is you are going to look for the external genitalia. Okay, forget. But what exactly are we talking about here? Is about the how these organs. Why I'm talking about is that the male will be having a scrotal sac, okay, where the testis is present, okay. It is also present on an external genitalia itself, and what actually happens is that there will be looping of. Can we make the diagnosis of the firm again? What do you mean firm? What do you mean by that, Benedict? Oh, film. Okay, yeah, sure. That is what I'm showing right now. You see here, when I'm trying to look at this abdomen, okay, the first thing I was able to recognize is that I see a Foley's catheter that is actually coming out. Okay, this is the Foley's catheter that is being present, and I can see there is a clear looping of the Foley's catheter. Okay, if there is a clear looping of the Foley's catheter, I came to understand that I am looking at a male patient. Okay, first thing, did you understand that one? I'm looking at a male patient. So if I'm looking at a male patient, I must be expecting a shadow of a scrotal sac. Yes, I must be expecting a shadow of a scrotal sac. Okay, doesn't matter even if the testicular size is small, big, you will be able to look at the scrotal sac as well. Doesn't matter. But when you look carefully along the below the regions of pelvic girdle, okay, pubic symphysis, okay, when you are looking below the region of pubic symphysis, I am actually seeing that there is a bag-like structure that is present down here with air in between them. Generally, testis is a solid structure, okay, which will be shown up as a hyperdensity. There will be no air inside the testis, okay. So if there is air inside the testis, what actually it suggests me that I will be looking at the intestinal organ. So I mean to say here that the intestine has passed down through the inguinal ring, and has come down into the scrotum. So in the scrotal sac, I was able to visualize air, which is actually telling me that I am looking at a patient of inguinal hernia. Simple. Benedict, is this clear now? First, I'm going to determine the sex, and then I'm going to look for the organs. Then I'm going to look for the densities, and air is present inside the scrotal sac is actually giving me a diagnosis of inguinal hernia. And yes, you can also see that there are abnormal dilatations of the loops of the small intestine proximally. Okay, abnormally dilated bowel loops proximally actually is suggesting me that and also comparing it to the scrotal sac abdominal contents, which actually suggests me, yes, the obstruction is present here in this distal region, which is completely hyperdense. Did you understand, guys? Is this okay? Did you understand it? Is this point clear for you? Yes, Benedict. What about Benedict? Okay, let me repeat once again. I am looking at abnormally dilated, okay, small intestines, okay, and then I am also going to look at the air that is present down below the pelvic region, okay, which is technically suggesting me that I am looking at a scrotal sac. How can I confirm that one? I'm going to look at the looping of the Foley's catheter, which is present and which is representing the insertion of the Foley's catheter through the urethral orifices. Okay, all the three parts of the urethra are being covered here. So that's the reason I'm looking at a male patient. And I'm going to recognize this condition as inguinal hernia by air presence inside the scrotal sac. And proximally, what is the condition? The condition is inguinal hernia, but what is the clinical diagnosis here? The clinical diagnosis is small intestinal obstruction because of abnormally dilated bowel loops that are present proximally and hyperdense regions that are present distally because the obstruction is happening in between. Yes, so that's how I came to understand that this patient is a small bowel obstruction which is happening because of inguinal hernia. Right? Okay, the same thing. Right now, when I actually took down a CT, I can see that there are abnormally dilated bowel loops, okay, with completely fluid filling in between them. And then I'm also going to look down at the scrotal sac, and I have been looking at the fluid that is filled up inside the scrotal sac. So fluid inside the scrotal sac generally is not present. What is if there is abnormally bigger scrotal sac that is present and fluid that is filled within the scrotal sac? What do you call that condition as? I think I told you last time. Hydrocele. What is the causative organism? Hydrocele is caused by a parasite. What is that parasite's name? Okay, come on, tell me what is the name. It is very simple. It is Wuchereria bronchofti, right? W bronchofti. Yeah, Wuchereria bronchofti. Yes. Okay, yeah, it's Helminth's. Wuchereria bronchofti is the one that is actually causing hydrocele. All right. Okay, filariasis, scrotal filariasis is caused by Wuchereria bronchofti, which is actually presents down as the abnormal filling down as the scrotal sac. So you should be able to differentiate this from scrotal hydrocele itself. Okay, right. So I think it is simple. You can see abnormally dilated bowel loops and a fluid also that is filled. And you can see here the loop is continued. See, the loop are continued and it is present. So which means to say, yes, there is an invagination of vagination of extension of the small bowel through the inguinal ring and going down into the scrotal sac. So inguinal hernia, right? And then gallstone ileus in the sense if it is related down to the cholecystitis, okay, will also cause small bowel obstruction. Intussusception, okay, we are going to look at this particular case as intussusception, which is a very particular thing to learn, okay. Intussusception is a clinical condition where, let us say, this is the lumen of the intestine, okay. I'm looking at the intestine, where the other part of the intestine should be continuous like this, but it is not happening. What actually happens is that this loop of the intestine now folds back, okay? Now folds back into itself like this, okay? It folds back into itself and it is forming, and this is actually causing an layer. So such thing is actually called as intussusception. Okay, invagination of the intestinal loop into itself is actually called as intussusception. Okay, clear? Did you understand? Intussusception is the invagination. You did not? Okay. Why? What seems to be the problem, Benedict? What seems to be the problem? Why don't you understand this one? Okay, okay, okay. I will explain once again. Just give me a second. Just a minute. Okay. See the blackboard? Yes. What exactly do you mean by a blind sack, Shubham? What do you mean by that? Okay, let's see. Listen carefully once again. Intussusception means to say here, let us say this is the intestine. Okay, okay. Let us say this is the intestine. Okay, generally what actually happens is that it has to continue, right? If it is going down as to the extension, if it is extending, it has to continue like this. But right now in intussusception, what happens is that this loop itself, okay, this part of the intestine itself is going to infold within it, and actually it is going to form a loop like this, okay, within itself. So this is actually called as intussusception. Invagination, okay, invagination. This is actually called as invagination. Invagination of a loop of a bowel, okay, into itself, its diameter, into its own diameter, okay, is actually called as intussusception, okay. Yes, blind sac, okay, if the ending is closed, obviously the ending should be closed, right? Okay, generally intussusception happens in colon. Yes, the blind loop will be present. So, but what actually happens is that the blood circulation will be restricted at this area. So the blind sac is actually going to become more gangrenous. Okay, the intussusception region is actually going to completely get compromised out of its blood supply. So the blind sacking will be present. Okay, generally the blind sacking will be present, and you are going to see a loop within a loop. Okay, when you are trying to, okay, let us say if I make a cross section here, what actually happens? The lumen has to be like this, right? The lumen has to be like this. But right now, where the invagination has already happened, what actually happens is that it will look like this. Okay, so this is actually loop within a loop. Okay, loop within a loop. So remember, this is actually called as target sign. Target sign. Okay, so loop within loop target sign is the characteristic radiographic feature of intussusception. Is this clear, Benedict? Shubham? Yes? Did you guys understand? Yep. Okay. So remember, target sign is the one that is actually present down as a intussusception thing, but you will not be learning in complete detail. Okay. But still, you understand that yes, intussusception will be happening down mostly in the ileocolic regions. Okay. And it is the most common form that is actually producing small bubble. Uh, Let me explain what exactly he's meant to say about this one. Okay. Check this. This is the ascending colon. Okay, ascending colon, and this is the ileocecal junction. Okay, appendix around this place. Okay, this is the appendix around this place, and the ileocolic junction. Okay, this is the ileocolic junction. Let us say small intestine is actually coming like this, right? This is the normal ileocolic junction. I think you know this anatomy normally. But what actually happens is that let us say there is an increased peristaltic movement that is here. All this peristalsis is happening. What actually happens at this junction is that right now the colon, okay, will go inside the small intestine like this, okay, inside the small intestine. Okay, let us say this is extending inside the small intestine like this, and then the small intestine is continuing. Okay, and now it is invaginating into itself. So, and then appendix continued like this. So this is the most common area of intussusception. So invagination of the intestine into itself is causing the small bowel obstruction. Now this one is the region of obstruction, right? So which one is the target here? Obviously the small bowel. So that's the reason I'm calling it a small bowel obstruction. Did you understand? Yes? Clear? Okay. Is this clear, guys? Now clear, right? Okay, see, it is happening down in the ileocholic junction, and right now it is invaginating itself inside it, and now it is actually causing what is it invaginating into? It is invaginating into small bowel. So that's the reason I am calling it as small bowel obstruction rather than calling it obstruction. Okay, colon is completely free in that area already. Next, inflammatory bowel diseases. Inflammatory bowel diseases like Crohn's disease and ulcerative colitis. Crohn's disease and ulcerative colitis are also different kinds of conditions that are actually calling small bowel obstruction. Remember, you will be learning this in fluoroscopy. Okay, I will again repeat this inflammatory bowel diseases in fluoroscopy because you will be looking at two important radiographic features here. Okay, uh, there is a lot to explain down because in the next chapter we have these fluoroscopic features of the inflammatory bowel diseases. You will be learning about their radiographic features. I will remind you once again when you are talking about this. Let's recall the causes of, okay, abdominal adhesions, okay, pelvic abdominal adhesions, post-surgical adhesions, okay, which is common during gynecologic and abdominal surgeries, malignancy that might be present down inside the lumen or outside the lumen, hernias, femoral hernia, inguinal hernia, direct hernia, indirect hernia, and then you are going to look for gallstone ileus, intussusception, and inflammatory bowel diseases are the most important causes of small bowel obstruction. Okay, and how are we going to recognize? I'm going to recognize it as multiple dilated small bowel loops, which are proximal in nature, and to the point of obstruction their dilatation will be greater than 2.5 centimeters. Okay, and what actually happens is that these small bowel loops continuously filled up with air and fluid over time, and they are going to stack one upon another to form a typical appearance that is called as the step ladder appearance. So step ladder pattern of the bowel loops is the most important characteristic radiological feature of a small bowel obstruction. That's the only radiographic feature you are going to remember. Okay, because that is the main important point when you are trying to write down the intestinal small intestinal obstruction feature. Okay, the other things, okay, continuous filling up of the air fluid levels, and then you are going to look up at the, okay, there is no air that is present down in the there is no air that is present inside the colon or rectum. That is how you are going to describe primary features and secondary features as well. Okay, and now they usually begin in the left upper quadrant and keeps on proceeding, and depending on how the distal the small bowel obstruction is, and they go down either down into the right lower quadrant or spreading down distally. Okay, depending upon the amount of obstruction, they are going to, the step ladder pattern is going to extend as smaller areas or larger areas. Okay, now on conventional radiograph, what we are going to look is, okay, there will be more proximal small bowel obstruction. Okay, if it is present down in the proximal jejunum, fewer dilated loops will be there, and more distal obstruction, like at the ileocecal valve, what we were talking about before, there will be greater number of small dilated bowel loops. Smaller bowel obstruction, okay, if it is happening at the level more proximally at the level of jejunum, they will be having fewer dilated loops. If it is happening more in the distal lesions at the along the ileocecal valve, yes, you will be looking at so many number of dilated small bowel loops. So the simple diagnosis is multiple air fluid levels stacked upon one another like a step ladder pattern is the characteristic feature of a small bowel obstruction. Let's try to look at the image. You see here, I'm looking at one bowel loop, one second bowel loop, third bowel loop, fourth bowel loop, fifth bowel loop, sixth bowel loop, some seventh bowel loop, and this is the fundal gas. You see here, and these are all the closed ends. These are all the closed ends. Okay, so all these one are actually going to form up the air fluid levels, and you will see here it has been extending from the left upper quadrant to the right upper quadrant. So if they are happening, I came to understand that this is a step ladder pattern. Okay, spring coiled appearance is lost, sphyngoid appearance is present, and then again step ladder pattern is happening one above the other. So this one, by this radiographic feature, I came to understand that I'm looking at a case of small bowel obstruction. Okay, so this one is actually the distal part of the small bowel obstruction happened. Okay, so that's the reason they extended from the right lower quadrant, sorry, left upper quadrant to the right upper quadrant. So sorry, right lower quadrant. They are going down to the right lower quadrant. Okay, extending down from left upper quadrant down to the right lower quadrant. So extending from left to right is the characteristic feature, and the step ladder pattern is actually increasing in size, increased but dilated bowel loops, okay, stacked upon one another is actually a characteristic feature of small bowel obstruction. Okay, is this picture clear? Yes, 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 no. Okay, so okay, this one is actually happening. Okay, we can know that this person is actually a carcinoma of the colon, which actually obstructed the ileocecal vein. Why? Okay, maybe somebody can be asking, how can I know that this is the carcinoma of the colon that is actually causing this one? Well, on a conventional radiograph, you will not be able to find that. Okay, but one evidence you can actually see is that there are bigger dilated loops. So many extra large dilated loops are present stacked upon one another. The first thing I'm going to think about is always a carcinoma. Okay, what is the organ that is present down distally to the small bowel? Yes, colon is the one. And what actually happens is that, okay, it could have been there is a colon, a cancer along the ileocecal junction or in the ascending colon or the transverse colon. That is the one that is actually going to cause a contractive obstruction, right? So that's the reason I'm seeing a lot of bowel loops that are present abnormally dilated. So multiple large bowel loops actually tells me that there is a distal obstruction, but smaller bowel loops, which is present something like in the proximal jejunum, if it is happening like that, smaller bowel loops will be seen, and I can understand that it may be a small part of the small intestine has been obstructed. Of course, it is distal obstruction itself. Okay, but proximal jejunum will be having smaller bowel loops, which is not technically like this. But if it is happening more in the colon, if the obstruction happening down more in the distal region, which actually along the ileocecal wall, which actually causes multiple air fluid levels like this. Okay, that is how we are going to differentiate it. Okay, and then decubitus radiographs, numerous air fluid levels will be present in the small bowel proximal to the obstruction. Do not forget this one, it is always proximal air fluid levels. And then if more time has gone, what actually happens is that to decompress and empty the bowel, the distal points, okay, there will be little or no gas that will be found in the colon. So secondary main important characteristic feature is that there will be very little or no gas that is found in the colon. Okay, I'm looking in the pelvic girdle once again, and if I'm going to find a hyperlucency there, it means to say I'm looking at the colonic gas, but that will be absent inside a this if there is a condition of small bowel obstruction, especially in the rectum, there will be no air. Okay, now you see here mechanical small bowel obstruction. You see here there are multiple air fluid levels, and you see here very little air that is present down in the rectal region, and you see here there is an extension of very multiple bowel loops that have been coming extended from the left side to the right lower quadrant, and I can see clearly see the volvula conventus here, which is looking like a spring coiled appearance, and you see here this whole loop became abnormally dilated, and you see here there is complete this area that is being dilated. All these one are actually multiple air fluid levels itself, but they are not looking like a step ladder pattern, obviously, but you are looking at this one as different loops and the large parts of the intestine that are being involved, and this can be happening in case of secondary to adhesions. So See, different radiographic images, okay, but still everybody is talking about the same condition, which is called as a small bowel obstruction. So this one, you can actually see here, the overall bowel gas pattern is disproportionate dilatation of the multiple loops of the small bowel, okay, and it is consistent with this mechanical small bowel obstruction, okay, and you can see here there is very small air that is present down in the colon, right? So did you understand here? Uh, yes, it is a small bowel obstruction. Yes, of course. Nashra, what the image what you have shown is, yes, it is a small bowel obstruction. Yes, right. That is actually the step ladder pattern. Okay. Nashra has been sharing up a very image that we were trying to look at, in the general principle slides. I have included that image. Okay, maybe I think you know about this image. You see, even it is present, the same image is present down in general principle as well. It is also present down in the practical slides also. Okay, if you can remember the abdominal x-ray indications in the general principle, I have included the same picture. Actually, yes, the picture I included there is the small bowel obstruction. All right. Okay, yes, of course it's a small bowel obstruction, Ashra. All right. Right. Okay. And see, then you are going to, what exactly is the problem here? You are going to compare it to the localized dynamic ileus, because early small bowel obstruction may be actually, you need to differentiate it. So how are we going to differentiate it? You are going to differentiate it clinically. Okay, the picture may be confusing, but you have to, one evidence that is there here is that there will be air, a large amount of air that will be present down in the sigmoid colon. Okay, so that is the main important radiographic feature differentiation. In the small bowel obstruction, you will be having only very little air, but in localized sentinel loop, you will be actually finding you will be finding more air. Okay, that's the radiographic differentiation, right? So look at here these images. You see here, I can see a spring coiled appearance, one bowel loop stacked about the other, and I can see here only very little air that is present down in the colon. And this one is actually also completely known as the small bowel obstruction. Okay, it can be actually partial. Okay, it can be complete or incomplete bowel obstruction. If it is a complete bowel obstruction, what actually happens is that uh, you know when you take actually the pictures intermittently, when you actually take down the pictures in different uh, you know views or different positions, what you actually see is that the obstruction will be persistent. Okay, persistence should be here, and also intermittent changing bowel loop shadows. And you see here in the supine position and in upright position, you see here almost I can right now visualize as the step ladder pattern. First loop, second loop, and third loop. You see here, and the air has completely moved, and now this area became much more hyperdense. See, in supine position, all the intestines came down to the abdominal floor. So that's the reason. Sorry, in abdominal floor, they came back to the retroperitoneum, and that's the reason air came back over to the abdominal surface. So that's the reason I'm looking at air all over the abdomen here. But in upright position, when the patient is standing, what actually happens is that the air goes up. So that's the reason I'm trying to look at this stacking pattern here. So supine position and upright position, both of them are going to be different. Okay, so you have to just see if which one is the supine position or which one is the upright position. Okay, it will be generally written down on the radiograph, so you have to look at the radiograph carefully and then try to understand if it is a small bowel obstruction, partial or complete or incomplete. Okay, so you see here, I can say that this is a partial obstruction because I can see the air that is present down here. Okay, right? And what actually happens is that the black arrow here is actually representing that the gas was able to pass down from the colon, and it is also visible on the large bowel. Okay, so the air is present down in the large bowel, but still I am looking at multiple air fluid levels. Okay, and abnormally dilated small bowel loops is actually telling that it might be happening because of a partial obstruction. Okay, then the same thing here. Okay, which is the disproportionate dilatation. Okay, disproportionate dilatation of the comparison to the large bowel. So that one is actually a suggestive of partial small bowel obstruction. Okay, disproportionate dilatation in different views and persistence of air or little air inside the large bowel is the partial bowel obstruction. Step ladder pattern is the complete step ladder pattern is a proximal dilatation due to the distal obstruction along the ileocecal wall. All right, and then abnormally dilated and the very no air that is present down in the rectum, and also only a small area that is presented, a small air that is present down inside the colon is actually talking about adhesions. So three different patterns you have learned here. Okay, see, step ladder pattern, then adhesions, then we are going to look at partial bowel obstruction. All of them are indicating the same clinical condition that is called as the small bowel obstruction itself. Okay, so there is not difficult. Okay, this is not particularly very difficult. In the coronal reformatted CT, okay, this is the coronal section. Okay, I'm going to look at the fluid levels that are present down inside the small bowel, and there is air present inside the colon. Okay, right, and collapsed colon, but very little air that has been present. And you see here, uh, I'm not looking at the dilated regions here. Remember, okay, this image is not showing up at the dilated regions. This is actually showing at the level of obstruction. Remember, okay, this coronal CT is the confirmatory diagnosis of the bowel obstruction. This one will actually show you to localize where is the obstruction. Since this is the area of the obstruction, so I'm looking at that level. But when I'm moving slides above, below, or anterior to posterior, I will be looking at multiple air fluid levels also. Okay. So with oral contrast or without oral contrast can actually demonstrate where there is the obstruction. Okay, so it is actually used for identification of the obstruction, or if it is present down due to the sentinel loop, okay, paralytic ileus, or if it is going to happen because of complete obstruction. That is why we are going to do CT. Okay, so CT is the most sensitive study. Okay, and it can be done either with the intravenous contrast. Okay, it can be used for detection of bowel complications of bowel obstruction, such as ischemia and strangulation. Ischemia and strangulation will be actually showing up the same radiographic features as if like in atherosclerosis, or if it is happening down, it is coronary arteriosclerosis. Okay, we are not looking where there will be no distal perfusion that is actually happening, and the contrast material cannot pass beyond the obstruction region. That is the same way how we are going to look at here also. It is not difficult, but the main important radiographic feature is here that you are going to localize the part of the obstruction, where exactly you are going to look at the particular location. And remember, you will be looking at a particular sign also that is actually called as the Beek's sign. Okay, which is actually showing up the blind sac. Okay, the blind sac will be recognized as a Beek sign. Okay, if it is in the abdomen, it is actually called as a Beek sign. But if it is shown up in the esophagus, if it is also called as the bird's beak sign. Okay, it is also called as Beek sign there. Okay, Beek sign on an abdomen represents intestinal obstruction. Beak sign in the upper GI tract represents achalasia cardia, okay, or strictures. Do not confuse yourselves. bird beak sign, you call it as beak sign or bird beak sign, okay, in upper GI, upper GI tract, okay, represents, okay, represents esophageal carcinomas, esophageal carcinoma, and achalasia cardia, achalasia cardia. Remember it that way. And beak sign of a closed loop in abdomen, abdominal film, okay, in abdomen represents small bowel obstruction. Okay, do not forget it. Remember it that way. This might be useful for your examination purposes. Okay, so bird's beak sign in upper GI, esophageal carcinoma and achalasia cardia. Okay, achalasia cardia, you can also see that there is also called as rat tail appearance. Okay, I will do that when we are talking about fluoroscopy there. Okay, it is still pending. Rat tail appearance. Okay, remember it that way. Appearance, okay, is a characteristic feature of achalasia cardia. I think I have told you last time. Okay, but big sign, esophageal carcinoma or achalasia cardia, or in particularly they are asking rat tail appearance, you call it as achalasia cardia. But big sign in an abdomen on a CT, okay, we do that on a CT, which is actually representing small bowel obstruction, okay, abdominal filling in abdomen. Okay, so CT findings, dilated loop 0.5 centimeter proximal to the site of, okay, transition point, okay, or the anatomical lead point where the bowel changes caliber and from dilated to normal, indicating the site of obstruction. So when you have found out the lead point, what actually happens is that the bowel changes caliber. Caliber in the sense the diameter, capacity of the filling up of the air or the fluid, and dilated to normal. Okay, distal dilatation of the bowel loops and proximal dilatation, the things that you find it on a CT. So in the absence of a mass or obstructive cause, what actually happens is the anatomical lead point, the cause can be always adhesions. Okay, you see here multiple air fluid levels are present down. Okay, multiple air fluid levels are present down, and this is the site of obstruction. Okay, right, the colon is the complete completely collapsed. Okay, and here you see here this black dotted arrow is the site of obstruction. Okay, colonic gas that is present down here, this is the site of obstruction, and multiple air fluid levels are present down here. Okay, so it can be happening in a condition called as Spigelian hernia. Okay, Spigelian hernia, this is actually happens down in the rectus abdominal muscles. Okay, where the small bowel is going to form from the Spigelian capsule. Okay, if it is going down from the Spigelian space or the Spigelian capsule, it is actually called as the Spigelian's hernia. So this condition is actually showing up this Spigelian's hernia. Okay, you will not be asked in depth for this one. You will be given down a simple image where you will be able to easily find out. Okay, collapsed small bowel or colon distal to the part of obstruction. These are other radiographic features. And small bowel feces sign. Okay, small bowel feces sign. Generally, small bowel do not have feces in them, but the feces actually should be present down in the colon. So what actually happens is that right now we are trying to look at the feces inside the small bowel. So proximal to the transition point of the small bowel, intestinal debris and fluid may accumulate, actually producing the appearance of the fecal material in the small bowel. So this is also one of the particular sign of the small bowel obstruction. Okay, big sign, small bowel feces sign, right? Step ladder appearance, okay, spring coiled formation, all of them are characteristic features itself. Okay, right, you can see here there are multiple air fluid levels. You see here abnormally dilated bowel loops. Okay, and here the solid black arrow is the one that is actually contrast filling here is seen. Okay, and then the dilated bowel loops are also seen. You see here abnormally dilated bowel loops. Remember, I am not looking at the colon here. How can I recognize the colon? I can recognize the colon if it is present down in the lumbar regions and it also having interrupted valvulae conventis. Okay. But here, this is, I can look at the valvulae conventis are completely continuous, right? From one extent to the another extension, one end to the other end. So I can know that I'm obviously looking down at a small bowel. Okay. And the white arrow you see here, this is the colon, which is completely present down in the lumbar region. So this one is actually completely collapsed. So second radiographic sign is present here, and this one abnormally filled, abnormally dilated bowel loops in the proximal regions are the one that is actually showing me that this is a case of small bowel obstruction. But you can also see in this patient that there is a small hypodensity that is present down on the right kidney. Okay. In the external surface of the right kidney, I can see there is a small hypodensity that is present. So small hypodensity, cystic lesions, okay, radiolucent or hypodensity that is present down on the external surface of the kidney is representing I am looking at corticorenal cyst. I think we dealt this about before. Corticorenal cyst. Okay, corticorenal cyst is actually being represented by a small hypodensity that is present along the external surface of the kidney or the cortical region of the kidney. It is called as a corticorenal cyst. So there is a corticorenal cyst that is present, collapsed colon that is present, completely abnormally dilated bowel loops along with multiple air fluid levels is the one that is actually giving me a diagnosis of small bowel obstruction. Remember these images. Okay. Next, the same thing, bowel enhancement is there. Okay, renal cyst, that is what we are going to find. And you can see here small bowel feces sign. Okay, there is all the feces, multiple small dots. Okay, small dots that are present down within the intestine is actually the air that is escaping down within the feces. And I can also see that there is proximally that there is a dilatation of the bowel loop here. Okay, and then the oral contrast is actually filling up. Okay, this one proximally dilated bowel loops. Okay, all the ones that are present. So the obstruction will be present much more distally. So small bowel feces sign. Okay, this is the one how I can actually recognize if it is a feces. I will be looking at smaller hypodensity air densities that are present within the uh, you know uh, hyperdense intestine. Okay, that is how I know that I'm looking at the fecal matter. All right, intestinal debris we call it as. So this must be happening because of the proximal to a small bowel obstruction. Okay, this is how we are going to see the feces sign. Okay, the obstruction is present much more distally. All right. Okay, so closed loop obstruction, the last finding, and then we're going to stop it. Okay, so closed loop obstruction, this is actually called as the blind sacking. Okay, closed loop obstruction, when 2 points of the same loop are obstructed, okay, at a single location, it is actually going to form a U shape or a C-shaped structure. And the most closed loop obstruction are caused by the adhesions. And in the small bowel, a closed loop obstruction actually causes a higher risk of strangulation of the bowel. Okay, in the large bowel, closed loop obstruction is actually called as volvulus. Remember, okay, let me explain this small thing. It is not difficult. Okay, right now we are going to talk about the coffee bean sign here. Okay, let us say I told this the invagination of its own loop is actually called as the intussusception, right? Okay, but volvulus is a condition something like this. Let us say this is the loop of the intestine. Okay, now what actually happens is that this is a single tube like this. Okay, there is a single tube, okay, which is continuous like this. But what actually happens is that right now, let us say that this loop, okay, now this loop will be twisting it over. It will twist upon itself. What actually happens? It will twist upon itself. Let us say now, right now, I am trying to twist here. I'm trying to make a knot here. Now, right now, this became something like this. Okay. And it became twisted. And it look, now, don't you think that this is looking like a coffee bean, Benedict? See, it is looking like a coffee bean. Yes or no? Right? These are the coffee beans, right? How the coffee beans look like. So let us say if I'm looking at the abdomen like this, a big coffee bean is looked, a big coffee bean is shown. Okay, so that is called as a coffee bean sign, and that is a characteristic feature. If it is happening down in the large bowel, we call it as sigmoid volvulus. Okay, we call it as sigmoid volvulus. Okay, sigmoid volvulus. Okay, these all these the things, the pictures and for practice are present down in your pathological slides, practical slides. Okay, you can look them and practice them. Okay, more images are there, you can understand. But right now what actually happens is that either they will form up a U shape or a C shape because the intestine is twisting by itself. Okay, it is twisting on itself. So twisting on itself is actually called as volvulus revolution. Valve there. Okay, volvulus means to say rotating. Volvulus. Okay, it is actually called as volvulus. Invagination itself is actually called as intussusception. Okay, intussusception is different, volvulus is different. If it is happening down in the small intestine, you call it as a small bowel volvulus. But if it is happening down in the large bowel, you call it a sigmoid volvulus. Okay, in sigmoid volvulus, you are generally looking at the coffee bean sign. Only a single coffee bean. Okay, large part of the intestine looks like a big coffee bean that is present down on the abdomen. Okay, it looks like this. The density actually looks like this. Simple. Okay, all of this one is air, one single loop here that is present. So it is actually happening because of the twisting of the intestine. Okay, twisting of the intestinal loop. So that is how we call it as a coffee bean sign. Okay, that's it. And see, this is the twisting of the intestine. Okay, and it looks abnormally dilated. Okay, so there is a closed loop. Cl is the one that is actually causing as a closed loop. Okay, so and you see here when you look closer, it is actually showing up as a a very small area. Okay, the loops when you actually, okay, this is the closed loop obstruction. When you look closely, okay, when you look closely, what are you actually looking at here? You see here there is a small place where the arrowhead is pointing out. There became a very, very small point. Okay, that one is actually called as the bird beak. That is actually called as the bird beak. You see here when I'm pointing it out, it is actually pointing, it is a small point. Okay, see, this is actually called as the beak sign. So beak sign is the one that is actually representing down a closed loop. Clear? This one is actually causing a closed loop. So beak sign here, coffee bean sign, okay, and then a closed loop obstruction, abnormally dilated. Okay, all of them, all these things what we learned from for the last 10 slides, all of them are the characteristic features of small bowel obstruction. Okay, right? And then you see here, this is the one also. Okay, and here we can actually see the closing looped obstructions are the one that is actually causing the compromise of the blood supply, and then there will be bowel necrosis. So you can also expect the patient to have a septic shock. Okay, right? Strangulation, uh, vascular compromises can be happening, and this one is the one of the most important complication, and you will not be seeing any kind of enhancement of the contrast material. Okay, no, it actually means tying off the bowels. Okay, it is tying, twisting off of the bowel upon itself. Okay, maybe I think you will, when you look at the images, because I don't have gross anatomical images right now in this theoretical slides. Okay, Let me see. Small bowel obstruction, gross anatomy. Let me find out this image for you so that you can actually understand. Let me find it. Wait. Okay, maybe let us say volvulus. Let me find. Okay. Okay, look at this image. Okay, look at that image, and that is actually by looping of one itself. Okay, and here. So that is the gross anatomy. See? Can you see that images? Okay, did you understand now? It is actually its own, looping of itself. It is actually completely twisting, and you will be actually forming up a small loop. So that is how the volvulus actually looks like. Okay. Because since you guys did not complete surgery and other things, so that's the reason you are. It is a little difficult to understand. Okay. But still, in the pathophysiology, you will learn them again back in surgery too. But first things you actually have to understand that you need to diagnose them on a, basic radiological images. You have to suspect if there is any suspicion of, you know, small bowel obstruction. This is the basic thing, because first thing you are going to look at is the radiograph, and then you are going to look at the surgical methods, right? Okay, so contrast material enhancement will not be seen. Okay, the contrast material enhancement is not shown. Okay, all these places we have contrast material which will seen, and distal contrast enhancement is not there, which actually suggests me that there is a bowel necrosis that is happening. Okay, so that's it. Okay, guys, I still have something around like 30 slides to complete. If you guys want to have a break right now, we will have a break for half an hour. Okay, and then I will take another half an hour more, and then I will complete off this gastrointestinal system. Okay, do you guys have any other class today? No? Okay, then, okay, I think it's all time for lunch. Okay, let us take a break of something like half an hour to 45 minutes. Okay, and then I will complete off the whole chapter itself. Yeah, I know. So I'm going to stop it here. Of course, I'm going to stop it here. Okay, right? Of course, I'm going to stop it here because I have only 30 slides left, right? Yeah, since because I will try to use of this one so that we will start freshly with skeletal system next week, so that you will have a lot of time. Okay, for this whole week. Okay, I'm not going to disturb again on you on Friday, Saturday, Sunday, nothing. Okay, I will take maybe something around like another 1.5 hour. I still have fluoroscopy and all other things. Only important points I'm going to cover them, which will be asked for MCQs. Okay, only that I will complete. And in this chapter, large bowel obstruction, I'm going to complete off that one will be completely fast enough. Okay, let us take a break. Okay, have your lunch, 45 minutes to 1 hour. Okay, something we will start. Okay, it's 2:30. We'll start around again at 4. Okay, then I will take around like 1.5 hours, and then we are done with complete gastrointestinal system. Okay, is that okay? Fine, guys, right? Okay, we'll take 1 hour break. Okay, we will meet around at 3:30, 3:45 or so. Okay, take your break, take your lunch. Okay, I know it is hard. I don't want to torture you guys like this itself. I know it, but let us complete our gastrointestinal system. We'll start freshly with, because there are only 2 chapters left later. Skeletal system, central nervous system. If both are done, yes, your radiology classes are done. Okay? No teacher, no torture. Okay, fine. You mean to say I'm not torturing you, or you don't want me to torture you? Are you suggesting me that I'm not torturing you, or you don't want me to torture? No torture बोले तो torture मत करो कि मतलब है क्या? Okay, fine. Do one thing. Okay, take a break. Okay, we will try to meet around 3:45 or 4, which means to say 6:30 in Chinese time. Okay, 6:30 at Chinese time, almost around 3:45. 6 o'clock in Chinese time. Okay, maybe 15 minutes of gap. Okay, take 1.5 hour gap, and we will come. Okay, complete your lunch and all other things. Okay, and we will start fresh, and we'll complete our gastrointestinal system. So that's it. Okay, we'll meet again in 1.5 hours or so. All right, bye bye. Part in it, and then also we came to understand about the radiographic features that is related down to the small bowel obstruction. Now we are going to talk about the mechanical obstruction that is related down to the large bowel. Okay, so first let us try to understand the pathophysiology of the large bowel. Okay, the same way like the small bowel obstruction, even here the lesion is actually present either inside the lumen of the intestine, the large bowel, or outside the colon, and actually causes the obstruction to the lumen. Okay, so over time, again, the point of obstruction backward, again, the large bowel dilates. Okay, where before the small bowel dilates, here the large bowel starts dilating with the cecum frequently attaining the greatest diameter, and if the obstruction is as far away as the sigmoid colon. So it's the same mechanism here also. Okay, it causes proximal dilatation because of the distal obstruction. Okay, so where the proximal parts in the jejunum, which caused actually proximal dilatation as the smaller air fluid levels, or if it is present down at the ileocecal wall, which has presented down with the large air fluid levels extending all over the abdomen as a stepladder pattern. Okay, here it's if the lesion is present down in the sigmoid colon, yes, there will be proximal dilatation and technically happening down in the parts of the, the large intestine, which is the ascending colon, the transverse colon, and the descending colon. So that is the parts that are present proximal to the sigmoid colon. So that's the reason we are going to work backwards. So do not confuse here one thing. When the obstruction is present down in the sigmoid colon, okay, when the obstruction is present in the sigmoid colon, what we need to do is that we need to find out the dilatation along the backward regions. Okay, so the proximal region that is present down along the above the sigmoid colon is the descending colon, and then the proximal to the descending colon is your transverse colon, and the proximal to that one is actually the ascending colon itself. So that's the reason I say that we are trying to work backwards in this condition. Okay, right? Is this point clear? You are not actually looking for the ascending colon first, but we are actually looking down for the descending colon, transverse colon, and then the ascending colon. So you are actually going down in the reverse uh, anatomical areas. Okay, right. And then the large bowel actually, the main important function of the large bowel is to reabsorb water, and therefore usually few or no air fluid levels are seen in the obstructed colon. So the main function of the large bowel is to reabsorb water, and while the water is being reabsorbed, generally there will be no air fluid levels, or very little fluid levels will be seen in the obstructed colon. And as the time passes by, what actually happens is that there will be continuous peristaltic movements, and to from the point of obstruction and forward, to empty the colon distal to the obstruction. Okay, so distally you will be actually looking down the peristaltic movements, okay, which has started from the point of obstruction, and they move forward in an attempt to empty the colon. Okay, colonic emptying will be done here. Okay, and usually for that reason there will be little or no air found in the rectum, and it is one of the most important radiographic features that is related down to mechanical large bowel obstruction. All right, so the key imaging features of the large bowel infarction, okay, are the obstruction, also you can call it as that way, and it is happening, there, as they do not tend to overlap each other. Okay, the small bowel loops are technically overlapping with each other, and they are actually forming the step ladder pattern. But here they won't be overlapping each other. Okay, and it is uh, possible to identify the site of obstruction on a conventional radiograph itself. Okay, and we can actually see again the closed loop thing, the closed loop section. You can actually see that that is the point of the site of obstruction. Okay, so that wherever you find out a sudden breakage down inside the colonic shadow where the air should have been present, but if you are not finding it, and it means to say that is the site of obstruction, generally, which is the last air containing segment of the colon. Okay, so just proximal to that one is proximal to this last air containing segment of the colon. Once you recognize it, proximal to it are the air filled regions, and distal to it are the hyperdensities that should be present. All right, and then so let us try to look at this image here. Okay, you can see large intestine is generally present down in the lumbar regions. Okay, in this x-ray you are going to look at the lumbar regions, and you can generally see here there are hyperlucent shadows. Okay, hyperlucent shadows, that hyperlucent shadowing actually suggests that these are abnormally dilated colonic loops. Okay, abnormally dilated colonic loops. So which means to say, the here you can see here there is a sudden droppage. Okay, there is a sudden droppage, and you can actually see the last air containing segment. So which means to say the obstruction has been causing by distally located areas. Okay, so that's how you're actually going to see. You are going to look at the dilated bowel loops along the lumbar regions, and then they are extending depending upon the transverse colon, ascending colon, and the descending colon locations. Okay, you're going to look at the hyperlucent areas, something like this, and they are abnormally dilated. And you can also see a last air containing segment that is present down on the left iliac region. Okay, so that is the solid area, and so this is the proximal region to that one. Okay, this is the proximal region to that one, starting from left side to the right side. So this proximal region has become completely dilated, and there is the last air containing, and it suggests that there is an obstruction that is present down distally. Okay, so distal obstruction. So what is the distal organ that is present to this one is the colon. So the patient might be suffering from a colonic carcinoma, which happens inside the lumen, right? But however, you have to also see that there is another uh, one observation you can be actually making from this image is that some of the gas has already passed backward through an incompetent ileocecal wall. Okay, so generally you are also looking at the small bowel pattern together with this one. So the increased pressure in the descending colon, transverse colon, and the ascending colon, a completely one is actually going to push the ileocecal wall present around this region, and it is going to push up. This pressure is going to build up, and it is going to make the ileocecal wall incompetent as well. And then you are going to sometimes look along the dilated ileal shadows. Okay, ileal shadows, small intestinal shadows can also be seen. So this is what this region is representing all about. Okay, so one thing you have to see is that, okay, depending upon the site of obstruction, uh, the more air filling will be seen in the proximal regions. Okay, which is the most proximal region in this image? It is actually the ascending colon that is the most proximal region. Okay, so that's the reason we are seeing abnormally dilated ascending colonic shadow in the right lumbar region, and proximal to it, you see here disproportionately, which means to say this region has got high and this region has got low, but still both of these segments are abnormally dilated. So that is what the most important clinical radiographic finding of a large bowel obstruction. Okay, so this is quite simple when compared to the large small bowel obstruction. And the most important, measurement you are going to remember here is that regardless of the point of the obstruction, what actually happens is that the cecum is always most dilated segment of the colon. Okay, cecum is the one that is actually cecum uh, is present down most of the times as the dilated segment, which you can generally see as extending from 12 to 15 centimeters, and it can actually possess a danger of the cecal rupture. So rupture of the cecal membranes can happen because of the building pressure that is inside the colon regions. And the measurement will be something around like abnormally dilatation greater than 12 to 15 centimeters. Uh, is the main radiographic feature that is indicating the large bowel obstruction. All right. And while the small bowel is not dilated, okay, unless there is an incompetent ileocecal wall, okay, the small bowel generally you do not see any kind of air that is present down in the small bowel. So, but you have to understand one thing, that in the small bowel obstruction, the air can be present down in the transverse colons and other parts as well. But because because the particles have to be moved forward, right? Because the distal segment to the small intestine is the large intestine itself. So that's the reason there might be air that might be containing down in the large bowel as well. But it will be compressed. It will be little air that is present down inside. But here you are going to find out a large air that is present down inside the colon. Okay, so that's one of the difference. And then here, because it is distal to the point of obstruction, generally there is no air that is present down inside the rectum. So you are going to look at the rectal shadow first, and then you are going to recognize, and then you are going to work backwards along the proximal regions, and then finally go to the point of obstruction. All right, and then here the large bowel functions to reabsorb water, and there are also very few air fluid levels present in the large bowel. This is, we have already seen that one, right? And as long as the ileocecal wall prevents gas from re-entering down into the small bowel in a retrograde direction, in the backward direction, okay, so we call it as a competent ileocecal wall. But the colon will continue to dilate and dilate in the ileocecal wall, because that is actually restricting the entry of air back into the small intestine, right? So it is actually working as a valvular mechanism. So that's the reason you see the dilatation mostly present down in the cecal regions rather than presenting down in the descending colon regions. Okay, is this point clear? Why it is only present down mostly on the right side? It is the reason because of the incompetent cecal wall. But if the cecal wall became ileocecal wall became incompetent, yes, you will be able to find out some air inside the small intestine as well. Okay, is this point clear? Yes. Okay. Okay. All right. So let's move on. So small bowel is generally not dilated in case of a competent ileocecal wall, and but in case of incompetency, the ileocecal wall opens and the gas from the dilated large bowel also gets decompresses back into the small bowel, much like air escaping from in a balloon, right? So this one is actually a therapeutic thing. So, for example, to say if there is an incompetence of the ileocecal wall that is present down during large intestinal obstruction, generally it is a good thing, right? There will be a good distribution of air all over the abdomen, and maybe sometimes in such kind of patients, the symptoms may not be well pronounced. The patient may not completely show up the abdominal bloating because of the incompetence wall, which the air starts to equally get distributed. But still, there will be increased pressure inside the cecum. Okay, even if the valve is incompetent, but still there will be increased pressure inside the cecum and they will be abnormally dilated. So doesn't matter wherever the point of obstruction is, you will be finding out a large air that is present down in the regions of cecum. Okay, and this can produce a picture of disproportionate dilatation of the small bowel and compared to the decompressed large bowel. So generally in such kind of a thing, if the competency keeps on incompetency is keeps on building and the air is equally distributed, so in such kind of situations maybe it is sometimes difficult to find out it is a mechanical small bowel obstruction. So at that point of time, what we are going to look for is to look at a CT scan in a sliced sections, and then we are going to look and locate the site of obstruction in the colon rather than in the small bowel. So we came to understand whenever there is an incompetent ileocecal wall, if you are suspecting that one, okay, you are seeing abnormally dilated, the large bowel things. Okay, so much air that is present down in the large bowel, and also some little to greater air that has been present down in the small bowel. You have to suspect, yes, this might be happening because of a condition called as ileocecal incompetence. So at that point of time, we are going to recommend a CT scan, and then we are going to look for the site of obstruction, and which you have to confirm that if it is present down in the colon or if it is present down in the small bowel. Generally, it is very easy. You will not be feeling very difficulty in doing this thing because uh, because what actually happens in the situation like a incompetent valve is that the disproportionate distribution of the small bowel air or the decompressed large bowel. In case of small bowel obstruction, there will be complete counteractive decompression because the air did not enter down into the distal regions, and distally present down to the small bowel is the ileocecal wall, and the air can abdominal contents are being pushed down in the distal parts, right? But here it is actually acting in the reverse direction. So it is easy that you can actually find out the site of obstruction presenting down in the colon itself, which actually indicates it is a large bowel obstruction. Okay, so let's try to look at this image. Okay, and here you can see here there are air-filled dilated loops down in the small intestine. So how can I know that this is a small intestine? Because I'm looking at the spring coil appearance, okay, of the valvulae conventus. And then uh, but this one is actually happening because of the carcinoma of the mid-descending colon. Okay, mid-descending colon has got the, you see here, abnormally dilated condition here. So which means to say, and also in the right lumbar region, also I can find this as an abnormally dilated large bowel. How can I recognize this is the large bowel? I can recognize the large bowel because of looking at the loops. Okay, intermittent loops that are interrupted loops that are present down here, and this is the continuous loops that are present down here. So I'm looking at tinea coli and valvulae conventus, and I'm trying to differentiate if it is from the large bowel or the small bowel. So this might be happening along the mid-descending colon because I can see here as a little air that is present down here. Okay, this is the mid part, and then okay, this is the mid part where the other part is present down here, right? So this is the mid part that is dilated, and then immediately on the right side, I am going to look at the ascending colon where it has been abnormally dilated, but still the ileocecal wall is incompetent, and then you see here that there is air also present down. But still, the clinical diagnosis obviously doesn't change. It is indeed the large bowel obstruction, but still it is masquerading with the small bowel obstruction as well. Okay, it is just mimicking. Okay, it is looking similar to a small bowel obstruction, but still, how can I find out the evidence? I can find out the evidence because there is a hyperlucent area in the right lumbar region, which one is the first main radiographic feature. So that is how I'm going to look when I started working from the backwards in the proximal regions, and this is the most proximal region and the most dependent. But still, I can the confusing part here has achieved because I'm looking at the air in the small intestine shadows as well. So when I'm trying to look at this one hyperlucent areas that are present down in the small intestine, and it actually suggests to me that maybe I am looking at the incompetent ileocecal wall. Okay, but this is not due to a small bowel obstruction. But in the small bowel obstruction, if this could, in this case, could have been a small bowel obstruction, what I will be looking at is, a decompressed air that is present down in the colon. But still, it is not there. So that's the reason I can say that yes, a small bowel obstruction along with large bowel obstruction could have happened. But generally, there will be no two obstructive sites. It is technically very rare because it actually depends on the particles that are trying to obstruct the lumens. Okay, generally a single segment will be involved, not double segments will not be involved. All right, so that one. And I can also see that the cecum contains air, and this is actually the real radiographic picture, which is actually suggesting me that indeed I'm looking at a large bowel obstruction. Others, I think it is quite clear for you guys right now. First, I started to look at the last air containing loop. Okay, so this is the closed loop, and then once I recognized it, I started working proximally towards it. So proximally, when I find out that in the left lumbar region, I find it as much more hyperlucent shadows, which means to say there is so much air that is present down here. And when I'm moving proximally to those other parts, what actually I'm trying to look at is the abnormally dilated large bowel in the right flank regions or the right lumbar regions. But I can also, at the same point of time, I'm looking at the radiolucent shadows that are present down in the small intestinal areas, okay, in the periumbilical regions as well. And then what actually, when I'm trying to find if this is the problem of the small bowel or the large bowel, when I question myself like this, I can actually understand that the maximum abnormal dilatation is seen along the level of the colon, ascending colon. So that is telling me that this problem is indeed a large bowel obstruction, and the obstruction that might be present down is here. Okay, so last containing area is the one that is the closed loop, and that is from where I am working proximally to find out all the contents. All right, and generally in any kind of intestinal obstructions, you see here the most important contraindication is you are not going to go for a barium study. Okay, remember that one. Large bowel obstructions or small bowel obstructions are generally a contraindication for the barium contrast study because the metabolism of the barium actually requires water, okay, and it will be excreted down as the feces. Okay, remember the metabolism, like I think one of your students also asked me the question, sir, why do we actually do not prescribe barium during intestinal obstruction conditions, and why barium is considered known as an inert contrast material. Okay, is that student, who is that? I don't remember exactly the name. Is that student present here? Some girl asked me about this condition. Yes. Okay, maybe let me try to interpret this question once again for you. Okay, Barium sulfate is a contrast material, right? And I told you that it does not have any kind of a pharmacological properties, and it is considered down as the inert substance. And when you are trying to give barium sulfate to the people, will there be any kind of side effects? Okay. Well, yes, there will be some certain kind of side effects, which is related down to vomiting, diarrhea, okay, and mild grade of hypersensitivities can be seen in case of barium studies. But generally, those are very, very mild and they can be controlled. They can be well controlled. But unlike the iodinated contrast materials, which are excreted by the kidneys, okay, which is an intravenous contrast, and barium sulfate is a salt and it is actually given down by mouth, which will actually the excretion of the barium sulfate will be happening down in the form of feces. The person will be passing out white color feces for few days, okay, because complete excretion of the barium is not happening because of hematogenically. It is not happening in the urine, it is happening in the form of feces. But when there is an intestinal obstruction where the absorption of water happens in the large intestine, so that's the reason in and barium is actually mixed up with water, and excretion of the feces also requires water. So that's the reason, we are not administering barium sulfate in these patients, and it is completely contraindicated. Okay, you can understand. Maybe this could be also one of the reasons when you see in normal people also, where who in people who actually consume little water, okay, less than something around like 2 liters of water in a day. If they are consuming very, very less water, where it is anticipated to consume around 4 to 5 liters of water in a day, these people might be suffering from constipation, okay, because the large bowel requires water and it will be absorbed back in the colon, and that one is actually the one facilitating the peristaltic movement inside the colon and pushing down the fecal matter down into the colon and finally reaching down into the rectum. But this kind of mechanism is completely lost in case of large bowel obstruction. So that's the reason the patients will be complaining of constipation as well. Okay, right. So how do we recognize the large bowel obstruction on a CT? Okay, CT is obtained to identify the cause of obstruction and also assess the free intraperitoneal air and identify the associated lesions such as metastasis to the liver or the lymph nodes. Remember, large bowel obstruction, colonic cancer, all such kinds of conditions are malignant tumors, and they will be having metastatic lesions down into the liver or into the lungs, okay, which are the primary sites of metastasis. And large bowel is dilated to the point of obstruction. So the dilatation will be seen as a very, very long segment until to the obstructing lesion, okay, and then the segment that is presented distal to one is actually is normal, okay, normal in the sense of normal diameter, okay, the distal segment will be normal diameter, but the proximal segments will be completely abnormally dilated, okay, and the point of obstruction is frequently carcinoma, okay. One of the best examples is the colonic carcinoma, which can be located down as a soft tissue mass, okay. And then hernias containing large bowel are also easy to identify on a CT scan. Okay, if it is happening because of the hernia, okay, it's a left-sided hernia or the right-sided hernia. Generally, most of the hernias happening due to the large bowel obstruction are generally coming down on the left side. Okay, right? Left-sided inguinal ring, yes, most of the times the hernias on the left side frequently cause the large bowel obstruction. Okay, right? So most of the times for both the large bowel and the small bowel, both of them usually have the same kind of, causes, etiological factors. All right. And you can see here, this is a coronal section of the abdomen, which actually showing up the abnormally dilated bowel loops, okay, and I can recognize this one as the large bowel because of the interrupted, okay, interrupted valvular conventus here, right? And you can see here when I'm moving proximally, I can almost see that there is an obstruction that is present down in the proximal most segment of the large intestine. So this is the site of infection, and I can almost see here there is a lot of debris that is present down here, which is actually indicating that I might be looking down at the fecal matter. And you see here, this is the obstruction level. Okay, so see the air that is present down here. So this is the last air containing segment that I'm looking at. In the same patient, we have taken down the CT scan, what we observed on the radiographic image. See, I'm looking at the fecal matter here, okay, and then I'm looking at the last segment here, which is actually the one that is indicating the soft tissue mass here, okay. And can somebody tell me if this is a plain CT or a contrast CT? If this is a plain CT or a contrast CT? Hello? Okay, this is a plain CT. I know that this is a plain CT because I can see at the aortic shadow, which is fluid basic density. But if it could have been a contrast CT, I will be looking down at the aortic shadow as a hyperdensity, right? But it is a plain CT, and I can see the last segment, which is the site of obstruction, and abnormally dilated proximal segments of the large bowel. So it suggests me that this problem is indeed the large bowel obstruction. Okay, uh, right. So then this is the feces. Okay, this is the feces. This is the site of obstruction. Okay, right. Then volvulus. Volvulus is again an important condition. Let's try to understand this one. Like I said, volvulus is the twisting upon itself. Okay, the intestinal part is actually the generally it might be happening in the sigmoid colon. Okay, that is the most important area, most common area where the volvulus or the twisting happens. So which one is actually causing a mechanical obstruction? But you see here, this mechanical obstruction is not happening because of a mass or a solid tissue that is present inside the lumen. The lumen is actually becoming narrow because the intestine itself is twisting upon itself. Okay, so that's the reason it is actually causing mechanical type of obstruction of the lumen becoming narrow. So lumen becoming narrow is obviously called as an obstruction, but this is not a true obstruction, but it is actually happening because of the twisting upon itself. So sigmoid volvulus is more common and actually tends to occur more in elderly men. Okay, and then the volvulated sigmoid colon actually assumes a very massive size. Okay, it will be extending all over the abdomen and rising up from the pelvis with the wall between the twisted loops of the sigmoid and forming a line that points down to the left lower to the right upper quadrant. Okay, so it will be forming up a very odd, which is taking up all the space of the abdomen, where the sigmoid forming a line. Okay, right, sigmoid colon that actually forms a line from the left lower quadrant to the right upper quadrant. So it will be looking down as a coffee bean sign. Okay, you see here, when this is what I'm trying to say here, this is the sigmoid colon line, and it is extending from the left up lower quadrant to the right upper quadrant. You see here, that is a big dilatation of the large bowel. So such kind of a thing is actually called as the coffee bean sign. Okay, so massively dilated colon. Okay, this is the massively dilated colon, and then which is actually twisted upon itself. So radiolucency upon radiolucency is seen in case of a sigmoid volvulus, and then in the center you are going to see a line. Okay, And where is the twist? Actually, the twisting must have been present down around this place. So that's the reason I came to understand that this is a sigmoid volvulus. So the most important radiographic feature is the coffee bean sign. Okay, remember, coffee bean sign is a characteristic feature of sigmoid volvulus, and there will be massively dilated sigmoid colon, where which one is actually shown up as a solid white line, and then which is twisted upon itself, okay, which will eventually cause the massively dilated radiolucencies present one upon another. Okay, this is the dilated colons, okay, and these are the air that is present down also here, okay, and there is a solid white line that is present, that is representing the colon, sigmoid colon as well. That this is actually happening because of the twisting that is present down around this place. So coffee bean sign is a characteristic feature of a sigmoid volvulus, right? And the point of obstruction is distal, okay? So there is air and stool that is present down in the proximal portion of the colon, okay? You see here, smaller white inhomogeneous shadows are also seen along this area, and that one is actually representing that this has been filled up with the feces, okay? A lot of feces will be present down here, and it is actually one of the reasons to produce a massively dilated loops when compared to the large bowel obstruction, which is happening because of the colon cancer, or the proximal segments, or the mid-descending colon segments. Here you can see that this dilatation is technically much more bigger than this one. It is actually extending more than 20 centimeters and is taking up all the space in the abdomen. So that's the reason volvulus is a very important condition, and it is an emergency because the strangulation can also happen in these patients. Twisting can happen, so twisting will actually compromise the blood circulation, and it is also one of the most bigger emergency. And when you actually try to understand here, uh, you see, when you try to understand here, since there was a twisting and there is a larger part of the sigmoid colon has been affected here, and you see here, since there is a neurovascular compromise, what actually happens is that this is going to lose the peristaltic movement and also lose the blood circulation to it, and all that part is going to rot. Okay, it is going to form up a gangrene, it is going to necrotize, and the whole cells will be dying within no time. So whenever you find a patient with sigmoid volvulus or a radiographic sign representing sigmoid volvulus, it has to be directly presented down to the surgical department. Okay, not even surgical department, you need to be transferring him to the operation theater right away. Okay, and if it volvulates, that is actually going down from the right lower quadrant to the left upper quadrant. Remember the mechanism, and you have to learn about what is the twisting cause, and the dilatation is actually seen from the right lower quadrant to the left upper quadrant, okay, which always can be seen in a case of a sigmoid volvulus. Uh, and you see, but volvulus of the colon will actually show up in the right lower quadrant to the left upper quadrant, okay, but that one is actually opposite, right? Here we will be looking at the left lower quadrant to the right upper quadrant. So this one is the sigmoid volvulus, and this one is the volvulus of the colon from the right lower quadrant to the left upper quadrant. Okay, so a contrast edema can be both diagnostic, okay. You see here, they understand one thing here, that the problem is actually present down in the cecum, right? The cecum is the one that is actually volvulating, which means to say the rectum is completely patent. But before, the problem is present down in the colon, and it is present down in the rectal areas, okay. But here actually the rectum and other things are completely fine. So contrast enema with barium study is generally not contraindicated here in this situation, okay. Volvulus of the colon, yes, it can be, since the rectum and the sigmoid colon are completely patent, so that's the reason a contrast enema can be seen. And generally you are going to see the Beek's sign also in these patients. Okay, beak sign is a characteristic feature, and it can also be seen in the volvulus of the colon. Okay, and it is also therapeutic because the hydrostatic pressure that is actually given by the pushing up of the enema will actually try to decompress the volvulus. Okay, because of the twisting is present. Okay, let us say if you have twisted a balloon and right now you are actually trying to push the air from one side to the other side, will actually technically relieve the the pressure or the twisting that is being caused by the valvulatory movement. Okay, so generally it is causing the hydrostatic pressure and it is trying to decompress by itself. So generally, but this is a therapeutic sign. But when compared to the volvulus of the sigmoid colon, actually this one is an emergency. But volvulus of the colon, sigmoid colon is different from the volvulus of the colon. Okay, so that's what I actually meant to say. The locations are entirely different. And this one, contrast enema, can be diagnostic as well as therapeutic because the hydrostatic pressure of the enema can sometimes decompress the volvulus. Okay, you can see here the left lower quadrant to the right upper quadrant. Okay, right lower quadrant to the right left upper quadrant. Okay, so you see here this one is producing down the big sign. Okay, the big sign is present down here. Okay, this one also looks like a coffee bean, but still you have to know that this one here, you see the contrast enema that is present down here. Okay, I can see that the contrast enema is present down in the colonic rectal area, and it is actually showing up at a sudden uh, droppage and forming out a pointed area. So that is actually telling me that this is the site of obstruction. Okay, so because I cannot see the passage of the contrast material beyond this point proximally, so that's the reason I am able to look at this one as a big sign. Okay, big sign of the obstructed sigmoid actually causes a big sign. So remember sigmoid volvulus and sigmoid colon, uh, sigmoid volvulus and colonic volvulus. Try to differentiate and try to remember the regions, and I think that is all for this whole acute abdomen conditions. Okay, so is there any doubt here? Is there any doubt? Is the point clear? Yes or no? Okay, right. What happened to all other guys? Why so many guys have been missing? Hmm? They doesn't want to study. So many guys are missing. Okay, now we are trying to understand. We will go with the new part. Okay, these very small points are present down here. This is to understand these parts. Okay, we are going to talk about the fluoroscopy of the small bowel and the large bowel. Okay, then little things, very smaller parts are here, and they are not technically very difficult to remember. uh, so we're going to start up with the small and the large bowel fluoroscopy. You have to see that the opacification and the distension of the bowel lumen is generally necessary for the evaluation of the bowel, no matter what kind of modality we are using. Okay, if we are doing it as the plain radiography, conventional radiography, or we are looking at the CT scan, or we are looking at the barium studies, generally we are not going to, look, we are always trying to look down for, this is the last part. I think I have left that one there, right? I think I told you that the fluoroscopy I will come down in the regional ways, right? Yeah, I think I have told you I still didn't complete the fluoroscopic part, right? No, but for these 20 minutes, I should not have even given the break before. Okay, so which modality we are using, we are going to always look for the opacification and the distension of the bowel lumen, right? And collapsed or unopacified loops actually can introduce the errors in the diagnosis, and which may be difficult sometimes to visualize. And then again, differentiation will be much more difficult, and artifacts will be present. Artifacts means to say radiographic signs that are radiographic opacities or densities that are seen acting as a pathology, but it is not actual pathology. So that is the artifacts. And accurate, something like the noise, we call it in a photograph, we call it as a noise, but in radiology we call them as artifacts. And to characterize them for recognition of any kind of pathologies, it can be difficult when they are collapsed or unapacified. So to remove such kind of errors, what we actually go down is that we are introducing the CT scan along with the fluoroscopy, or we are going to go for only abdominal fluoroscopy and try to understand what the pathology is presenting. Okay, because collapsed or unapacified bowel loops can actually see the give out the errors in the diagnosis. So that's the reason we are going to introduce much more advanced studies along, like mixing up of two radiographic modalities and then combine to look at the problems that are present on. So what we actually do is that orally administered contrast can be given, and then along with it a CT scan can also be taken. But remember, only in case of trauma. Okay, only in case of trauma, or we are actually trying to look down for the vascular structures or aorta as well. So uh, generally it can be happening only except for in case of trauma. Trauma is also one of the biggest contraindication for barium studies. Okay, remember, this is a very important question: what are the contraindications of barium studies? Okay, it can be asked down as a 2 marks question, or sorry, 1 mark question, or it can be asked as an essay question. In the essay question, you can actually be asked as a small part. Okay, so remember what are the contraindications of barium studies. Okay, so in what are we going to do is that we are going to combine the oral contrast and also perform the CT examination, except in case of trauma. Okay, and then we are going to dilute either the barium or iodinated contrast, and then finally try to observe the the examine and try to examine the abdominal structures. Okay, so here, like what we actually also what we have seen in conventional radiography also puts down into the same rules and regulations also follow up on the CT scan as well. So thickening of the bowel wall, and the normal bowel lumen does not exceed like about 0.5 centimeters, and generally the wall is not thicker than 3 mm. Okay, and the colonic wall does not exceed the 3 mm if the lumen distended. Okay, so these are the calculations you should be always be able to remember, where the small bowel lumen will be does not exceed greater than 2.5 centimeters. But if it is extending beyond 2.5 centimeters and it is showing a step ladder pattern, am thinking that I'm looking at a case of a small bowel obstruction. But if I'm looking at the cecal region and abnormally dilated greater than 12 to 15 centimeters, I'm thinking I'm looking at a large bowel obstruction. And when the contrast material is actually being given, the contrast material actually lines the mucosa of these intestines, and the thickening will not be seen, should not be seen greater than 3 mm. But if it is less than 3 mm, yes, you can say that the mucosa is completely normal. Okay, now here in this situation, you can see here there is a particular enhancement of the bowel walls. Okay, you can see that there is a particular enhancement of the bowel walls, and the distended, these large bowel areas are generally very thin. What actually I meant to say about this is that since there is no dilatation or there is no distension of the intestines here, so that's the reason they are generally only showing up the enhancement, but there is no distension. So this can be technically a normal image. Okay, sorry. But you see here, whenever there is an edema, okay, remember, or whenever there is an hemorrhage, there will be a very particular point, uh, like say, well, we can say that there will be a particular radiographic sign that is actually called as thumb printing sign. Okay, remember, thumb printing sign. Okay, thumb printing sign. Okay, thumb printing sign can be happening in clinical conditions. Sorry, can be happening in clinical conditions where there will be nodular indentations in the bowel loop, actually representing a focal area. Okay, submucosal infiltration by edema or the hemorrhage, or the tumors generally in lymphomas or amyloidosis. Okay, thumbprinting sign generally will be happening because of a clinical condition called as ulcerative colitis. Okay, there is also another clinical sign that is also seen. Okay, I will talk a bit, in short while, but you can actually understand that lymphomas, okay, lymphoma or abdominal lymphoma or amyloidosis or the ulcerative colitis is also showing up thumb printing sign. Remember, thumb printing sign is actually happening because of submucosal edema or the hemorrhage. Okay, the submucosal infiltration or thumb printing sign is actually showing up here. You see, there is an particularly increased enhancement. Okay, there is enhancement of all the areas, right? Okay, so in case of ischemic colitis, okay, this is also one of the clinical condition. Okay, if the colitis is happening and then there is ischemia that is present due to vascular compromise, we call it as ischemic colitis, and it is going to show up some hemorrhages, and so that's the reason this is actually called as a thumb printing sign. Enhancement of the bowel walls will be present, and then there will be ischemic region where this will be no particular enhancement. So that is how I'm going to know that this is a thumb printing sign, which is related down to ischemic colitis. Okay, sorry. And then hazy or strand-like infiltration of the fat can also be seen. And this one is actually extension of the inflammatory reaction outside of the bowel into the adjacent fat, which is actually a secondary finding or a sentinel finding that actually says that there is an associated condition that is present with it. Okay, so when you are looking at a hazy or strand-like infiltrations of the surrounding fat, same like what you saw in pancreatitis, fat stranding is nothing but the disruption of the or the loss of clarity along the pancreatic borders. That's the same way here we are looking at the haziness of the large bowel shadows. So when you actually see that one, you are going to think that you are looking at a case of inflammatory reaction. And such kind of condition is actually ulcerative colitis. Okay, right. And you can see here there is a lot of haziness of the bowel shadows that are present. Okay, and then there is also, there is some kind of an extra luminal air that is present down, so which is actually indicating that this is a sign of perforation. Okay, so you have to understand any kind of inflammatory condition causing down inside the colon or the intestines is actually likely to perforate. So perforation of the hollow viscous is going to happen. At the same point of time, you are going to look for another radiographic sign, which is actually called as a sickle cell radiolucency, that is present down the right hemidiaphragm. Okay, sickle cell, sickle cell hyperlucency that is present below below right hemidiaphragm. Okay, is actually a indication of pneumoperitoneum. I think I told you even last time. So sickle cell hyperlucency that is present below the right hemidiaphragm is a characteristic feature of pneumoperitoneum. And here, extraluminal air that is also present down here. So you can actually call this as a perforation of a hollow viscus. Okay, perforation of any part of the intestine, right? So uh, now we are going to learn about a very, very important disease. This can be asked for a 4 marks question or mostly, a MCQ, image-based MCQ. This is also very important for your, entrance examinations. A lot of competitive examinations frequently ask this question, which is known as the Crohn's disease. Okay. Have you ever heard of this name that is called as a Crohn's disease? Yes? Okay. But let us try to understand along with its pathophysiological mechanism and then try to relate it back to the radiographic features. Crohn's disease is a chronic relapsing granulomatous inflammation of the small bowel and colon, resulting in a lot of ulcerations, obstructions, and fistula formations. Okay, it is a chronic relapsing granulomatous inflammation of the small bowel and colon, which actually results in multiple ulcerations, obstructions, and fistula formations. Okay, so Crohn's disease generally involves ileum and the right colon. Remember the regions, okay, it is actually typically involving the ileum and the right colon, and where there will be things that are actually called as the skip lesions. Okay, a very important point. Okay, skip lesions are seen in, okay, skip lesions are seen in Crohn's disease. Remember, okay. There is a, I think, in pathology also there is a very important question that they ask. Okay, how do you differentiate between a Crohn's disease and an ulcerative colitis? Did you do this question before? No. Okay. uh, so if you want me to cover that part here, I will cover that part here. If not, maybe let us move into radiographic features. If you want to understand this disease, yeah, I will get down into deeper pathophysiology. If not, I will be directly going down into the radiographic features. Do you want to learn about this, or you just want me to skip off? In pathology, you should have learned about it. What does this yes say here? I mean, you want me to cover, want to learn. Okay. Do you guys want a break, or do you want me to continue? Okay. Okay. Right. Uh, wanna learn. All right. Okay. Because this is a very important, both of them are very important clinical conditions in our tropical countries. Okay. India and particularly African regions or South American regions, all these tropical countries, ulcerative colitis and Crohn's disease are a very important clinical diagnosis. Just give me a moment. I will try to uh, get one of my notes so that I can actually explain them in detail. Just a minute. Just a minute. Okay. Uh, First, while we are trying to learn about the ulcerative colitis and Crohn's disease, okay, there are few little things that we need to understand about them in particular. Let me write. Maybe you can take down the notes the way I'm following up with, okay? And so that you can actually understand what exactly are the differences. Let me see. Okay, maybe I will try to make up a table so that you can actually understand both of them together, and then I will cover off the radiographic features first. Because if you understand this part itself, it is very easy to understand the radiographic features. So maybe you can start making up notes along with me. Sorry, just give me a moment. Everybody see the whiteboard? Can everybody see the whiteboard? Yes. Okay. So ulcerative colitis and Crohn's disease are generally coming under the categories of inflammatory bowel diseases. Okay. They form under they come under the inflammatory bowel diseases. So what actually happens is, okay, look at carefully here. Okay, I'm making down as a small table. This is a very, very big table. There are a lot of points for us to remember here. Okay, so let us say I'm looking at Crohn's disease on this side, and then I'm looking at ulcerative colitis on this side. Okay, okay, both of them come under the category of inflammatory bowel diseases. Okay, now what actually happens is that first we are going to look at the involvement. Okay, what is involved in it? What are the anatomical regions that are involved in it? Okay, involvement. Remember, in Crohn's disease, it is actually, it is discontinuous involvement. Okay, it is discontinuous. Maybe take down a notes related to this one so that you can actually understand it is discontinuous, it is segmental. Okay, and so that's the reason there will be skip lesions. Okay, there will be skip lesions. I will explain what are skip lesions in a little while, but first try to understand this one. And this one is a continuous involvement. It is happening down continuously. Continuous. Okay, continuous. And then Crohn's disease actually involves entire GIT. Okay, anywhere, it can happen anywhere in the GIT. Okay, it can happen anywhere in the GIT, but ulcerative colitis generally is happening along the colon. Okay, generally happening along the colon, rectum. Okay, remember, colon, rectum, and in a retrograde fashion. Okay, retrograde fashion. It is happening down in a retrograde fashion. And it can happen anywhere in the GIT. Crohn's disease can happen anywhere in the GIT, but it generally will be seen in terminal ileum. Okay, it will be generally seen in terminal ileum. Okay, right? So most frequently it can seen anywhere inside the GIT, but this one will be seen mostly in the terminal ileum. Okay, and then Crohn's disease in rectum is very, very rare. Okay, rectum, in rectum, Crohn's disease is rare. But here you can see this one is the most frequent area. Ulcerative colitis in Colon and rectum happening down in the retrograde fashion is rare. And you can also see here terminal ileum is rare. In ulcerative colitis, terminal ileum is rare. This one is rare. Yes, is it clear until now? Okay, if you do not understand any part, you just let me know, okay? Yes, is it clear? Are you taking down notes? Okay, make it a complete page, okay? A large, there are so many clinical differences here, okay? And then generally these patients will be showing up, okay? These patients will be showing up in the anal regions as anal fistulas, okay? Anal fistula will be seen in these patients. Anal fistulas will be seen in these patients. And these patients will not be showing up anal fistulas, but these patients will be showing up proctitis, okay? Proctitis, okay? You will learn them in surgery also, but in pathophysiology, I think you should have completed this one. But since you did not complete, okay, so that's the reason why we are doing here, okay? Anal fistulas will be seen in Crohn's disease, where proctitis will be seen in case of ulcerative colitis. Okay, have you completed this one? I'm going to remove this one. Okay, right? Proctitis is the inflammation of the anal canal. Okay, inflammation of the anal canal. Okay, proctitis. Proctum means to say anal opening. So proctitis is nothing but inflammation of the anal canal. All right. Okay, I'm going to remove this one. Now, these people will have clinical features, clinical features, Crohn's disease. Okay, this is Crohn's disease here, and this is again ulcerative colitis. Okay, clinical features, these people will be presenting up with the chronic diarrhea. Okay, these people will come up with chronic diarrhea, weight loss. Okay, weight loss, and particularly megaloblastic anemia. Okay, megaloblastic anemia. This will be coming up with megaloblastic anemia. But in ulcerative colitis patients, generally they come up with pain, okay, and they will be coming up with a hematochezia. Okay, hematochezia. I told you what is hematochezia, right? Giving up fresh blood from the rectum is actually called as hematochezia, and then there will be showing up tenesmus. Tenesmus. Okay, tenesmus is again a clinical feature. Okay, so can somebody tell me what is tenesmus? Did you ever hear this term? Okay, yeah, feelings of you know urge of passing down the feces. Okay, it's not actually following the feelings of poo. Okay, you don't do it that way. You try to speak scientifically. Okay, frequent of urge to defecate. Yes, it is actually called as tenesmus, or you can also call it as straining. Okay, you can also call it as straining. Okay, straining. Right, so that is what the thing here. And then there will be abdominal cramps. Okay, there will be abdominal cramps as well. Just a minute, just a minute. I'm sorry, my notebook actually ran out of battery. So just a second. Okay. Can everybody see the whiteboard now? Yes. Okay. Okay. Right. So then on this side, Crohn's disease. Then we are going to learn about ulcerative colitis. Now you have to see here the microscopic involvement here in Crohn's disease. It will be transmural. Okay, it will be transmural. Okay, it will be transmural. So that's the reason these patients will be coming up with fistulas. Okay, and anal fissures, and sinuses. Okay, they will be coming up with sinuses. All right, but this one, these patients will be actually not involving only, these are not transmural here in these patients, but this will be mucosa and submucosa. Okay, mucosa and submucosa in ulcerative colitis patients. Then like I said, these patients will be frequently coming up with what do you say, these patients, Crohn's disease patients will be actually producing up ulcers, right? So both of them will actually give ulcers. Okay, ulcers, we are talking about ulcers here. When there are ulcers, what actually we can see is that these patients will be having a typical, very, very famous line in medicine. You know, all these patients will be looking at ulcers, and these ulcers are actually called as serpiginous ulcers. Remember, very important point. Okay, these are all actually called as serpiginous or serpentine. Okay, serpentine ulcers. Ever heard this term? Yes. Okay, ever heard this term? Okay, remember, but let me tell you what exactly is the serpiginous ulcers. Okay, and what actually serpiginous ulcers are means to say that they are continuous. Okay, they are continuous, something like this. Okay, serpiginous ulcers, let us say this is the lumen of the intestine, so they will be looking like snakes. So that's the reason it is actually called as a serpiginous ulcers. Okay, it is actually happening on the transmural membrane. Okay, also you are looking at, when you are doing colonoscopy, you are actually going to look at the transmural membranes. So that's the reason you look them as like snakes. So that's the reason they kind of ulcers are actually called as serpiginous ulcers. Okay, right. Then what I'm going to look in Crohn's disease and ulcerative colitis. Okay, this one will have serpiginous ulcers. Okay, and whereas these patients will be, since it is actually involving down in the mucosa and submucosa, so I'm going to only look at the superficial ulcers. Okay, superficial ulcers. Here I'm looking at superficial ulcers itself. All right, and these one are granulomatous. Okay, these are granulomatous and non-caseating ulcers. Okay, these are granulomatous and non-caseating ulcers. Okay, and generally these one are pseudo polyp types. Okay, this one is pseudo polyp. Okay, these are pseudo polyps. Okay, and since these all one are involving down in the transmural membrane, also means to say whole membranes of the the intestine is involved, so they are liable to produce fibrosis. Okay, they are going to produce fibrosis if it is happening down in the submucosal layer, and they will be forming strictures. Okay, they will be forming strictures. Okay, which Plus means to say yes, positive for strictures. They will be forming fistulas. They will be forming sinuses. Okay, sinuses all are present. But here, fibrosis, no, it doesn't happen. And strictures, never seen. Strictures never happen in these patients, never seen. Okay, and fistulas and sinuses are also no, it doesn't happen. Or if they are happening, they are very, very small and very, very rare. Clear? Okay. Yes. Okay. So what actually happens? Is this clear? Yes. Are you guys writing it? Okay. Okay. Perfect. So I'm continuing it. Then again here, since there are strictures, okay, since there are strictures, and since there are strictures, what actually happens is that all these strictures are coming together, and they are strictures are there, fistulas are there, all those things. When you actually take down a colonoscopic view, actually they will be looking down like this. Okay, all of them are actually looking out like this. Okay, so they are looking particularly like this. So such kind of appearance is actually called as cobblestone appearance. Okay, it is actually called as a cobblestone appearance. Remember, this is a very, very important sign. Okay, or which is also called as creeping fat sign. Okay, creeping fat sign. Remember, it is actually called as a cobblestone appearance or a creeping fat sign. And here, but these are actually forming up these pseudo polyps, right? These are, since they were forming out these pseudo polyps, okay, pseudo polyps thing. So that's the reason they also do not show any hostrations. Hostrations are absent. Okay, hostrations are absent. Okay, hostrations are completely absent, and they are actually going to show up a appearance that is actually called as the lead pipe appearance. Okay, lead pipe appearance. Remember, this is again a very important sign. Okay, it is actually called as the lead pipe appearance. Okay, then hostrations are nothing but the the folds. Okay, the folds of the intestine are called as hostrations, and then the villi are present down above them, right? So that is actually called as a hostration. All right. Okay, now then, because of this cobblestone appearance, what actually happens is that on radiography, okay, this is on colonoscopy. Okay, this is all on colonoscopy. Okay, this is also also you can see this one also on colonoscopy. Okay, colonoscopy. But particularly when we are finding out along these clinical features and along colonoscopy, generally we are going down to radiology, where you are going to find out all this evidence from first to the last. Okay, write down the involvement, okay, the anatomical regions involved, the ulcerations that are present, and all other features like fibrosis, strictures, all of that present exactly will be seen the same on radiology itself. So that's the reason why I wanted to introduce all of these features to you first before we getting down into the radiology. So in what happens in radiology, a very particular important radiographic science, do not ever forget in your whole lifetime about this, okay, because it is very, very important. Okay, The first thing, what actually on a radiography we actually see, on radiography we actually see a very classical and famous radiographic sign, which is actually called as the string sign of Cantor. Okay, remember this one, Crohn's disease, will show up, which is called as the string sign of Cantor. And this will also show again the same sign, which is called as the creeping fat sign on radiology also. Okay, a creeping fat sign on radiology. Here, ulcerative colitis also shows up a straight, okay, a straight tube or pipe appearance, which is again called as the lead pipe appearance. Okay, okay, lead pipe appearance. This one also shows up a lead pipe appearance. All right, and this one shows up a very special sign because it will be causing narrowing or because of the fibrosis, because of the the strictures or the fistulas that are actually formed. It actually shows up a narrowing of the whole terminal ileum, which is actually giving up again a very classical feature on radiology, which is called as the apple core deformity. Okay, which will give out apple core deformity. Okay, but here you won't be seeing any kind of any kind of fibrosis is present here, right? But if fibrosis is present, again the first sign you are going to look, okay, the first sign you are going to look in ulcerative colitis is loss of haustral shadows on radiography. Okay, loss of haustral folds, loss of haustral folds on radiography. Okay, simple, right? And so until now it is fine. Do not ever forget these radiographic features. They are very important. In so many examination papers you will be seeing these classical questions. Okay, string sign of Cantor is seen in, okay, creeping fat sign is a characteristic feature of, apple core deformity is a characteristic feature of, okay, apple core deformity on fluoroscopy is seen in, lead pipe appearance is seen in. Okay, so all such kind of questions will be asked classically, so remember them. And this is when you are trying to learn about surgery, you are going to look at these kinds of questions, and this is differentiation of all irritable bowel syndromes as a single question. When I used to learn MBBS, okay, they asked us the all explanation of all the irritable bowel syndromes as an essay question. So obviously, I got to learn at that point of time, and I still remember all these points. So it is a very important thing. Irritable bowel syndromes are very important in tropical countries. So remember all these points. Okay, right? And then finally, you are going to look at, this may be associated with a few other conditions, okay, Crohn's disease and ulcerative colitis. Um, they will be actually uh, associated with one thing that is actually called as ASCA. Okay, I will tell what is ASCA. It is actually called as anti-saccharomyces. Okay, anti-saccharomyces antibodies. Okay, anti-saccharomyces antibodies are seen in Crohn's disease, whereas ankylosing spondylitis, okay, ankylosing spondylitis, you will learn this one in skeletal radiology about this condition, ankylosing spondylitis, ankylosing spondylitis, and then anterior uveitis, okay, uvea in the eye, okay, anterior uveitis, and then you are seeing up a very different condition that is called as pyoderma. Okay, pyoderma gangreosum. Okay, pyoderma gangreosum, right? Or you can also call this condition as erythema nodorum. Okay, these names are quite famous. Okay, you will be getting familiar about these names later on in life. So in these patients, actually, we see anti-saccharomycin antibodies. But when you are seeing along with these all these conditions, ankylosing spondylitis will be there in these patients. Anterior uveitis will be present. Okay, eye inflammation, uvea of the eye is getting inflamed. Pyoderma gangreosum is present. Erythema nodorum is present. So in these patients, you will be looking at P. anca bodies. Okay, heard this term, I guess, right? ANCA antibodies. Yes, ANCA antibodies, ANCA antibodies. These are a quite famous, antibodies. I think you should have heard about them in pathology. Yes, no, no. Okay, okay. If they didn't teach you, I can't help you. But what is actually P ANCA? ANCA means to say actually perinuclear. Okay, perinuclear anti-neutrophilic, okay, neutrophilic cytoplasmal antibodies, cytoplasmal antibodies. Okay, perinuclear anti-neutrophilic cytoplasmal antibodies are actually called as P ANCA bodies. Okay, this is a very characteristic feature. It is actually the neutrophil infiltration is actually happening in ulcerative colitis. So in this one, we actually see anti-saccharomyces antibodies. In this, we actually see ANCA bodies. Okay, so I think that's it. That is what the differences between ulcerative colitis and Crohn's disease is. Okay, and like I was telling yesterday, toxic megacolon is also involved with this one. Okay, toxic megacolon is the one that is shown down with the Crohn's disease is more in ulcerative colitis. Okay, toxic megacolon here. Toxic megacolon is also seen in ulcerative colitis, and in Crohn's disease it is very rare, right? Like I said yesterday. So that are almost fine. So I think that's it. Nothing else. Maybe pseudomembranous colitis, yes, like yesterday, yeah, we saw it, right? Pseudomembranous colitis, toxic megacolon, yeah, it is seen in ulcerative colitis and Crohn's disease. That's it, right? Toxic megacolon. So I think that are the the features, the complete clinical information. Okay, from first year to last year, when you actually learn about that one, you have to by heart this table. It is very important because there are millions of questions that is always asked in any kind of a competitive exam. What are the difference between the ulcerative colitis and Crohn's disease? Maybe if you opened up any kind of MCQ questions, you will be seeing a lot of differentiating questions on this one. Radiology for ulcerative colitis and Crohn's disease, you have to by heart them. It is the ultimate gathering point there. Okay, string sign of Cantor, apple core deformity, lead hose appearance, all of them are very famous questions. Okay, but for this examination purpose in theory here in this what do you say in this examination, most probably I'm not going to technically ask about these conditions because it is beyond your scope. You should have already learned this one in pathophysiology, but since you didn't learn it, so that's the reason I wanted to take time and tell them here. Okay, so I think we are almost done here. Right now, since we know about these diseases, okay, while I'm teaching the radiographic science, look at your differences and try to understand the conditions. Okay, now it will become pretty much easy for you to understand this. Okay, so all the pathophysiology, all the next coming slides are also talking about these differences itself. So since we have made it, so I will directly skip down to the radiographic science so that you can actually understand there. All right, so after that I think we are ending the class here itself. Okay, so now you see here, uh, is there anything that is not understood here? I think you got all the differences, didn't you? You wrote down, right? Yes. Okay. Okay. Perfect. So you see here, Crohn's disease. Okay, Crohn's disease. What actually happens? Okay, it can be imagined. Okay, imaging of Crohn's disease generally can be done by the barium follow-through study at the CT, abdomen, and the pelvis. But generally, the confirmatory diagnosis actually is done by colonoscopy and pathological studies. But still, those are invasive. A non-invasive gold standard is actually, barium follow-through and CT scan. All right. So now imaging findings, what actually we see is that since there is fibrosis in this condition, since there is strictures in this condition, and there are ulcers which are serpiginous in nature, so that's what also we are going to find in imaging, right? See, narrowing, which is actually happening because of fibrosis and strictures. Irregularity, it is actually happening because of fibrosis which are irregular. And then ulcerations, the types of ulcers that we are seeing here is the serpiginous ulcers, and the location where it is present down in the terminal ileum itself. And it is seen frequently with the proximal small bowel dilatation. Now simple, I guess, right? You can remember the radiographic features as well, which is related down according to if you are remembering down the the locations, involvement, and anatomical regions and pathophysiology. Now, separation of the bowel loops will also happen, which actually causes a fatty infiltration, which is actually called as the creeping fat sign. I will show the images, you will understand them much better there. Okay, separation of the loops of the bowel, which actually causes the fatty infiltration of the mesentery, and that is actually called as the creeping fat sign. And making these loops stand apart from each other and surrounding loops of the one, which is also called as a proud loop sign. Okay, this is an extra thing. Okay, in most of the Western countries, they are also talking about the proud loops. Okay, so they generally what actually happens here, they make the affected loops stand apart from the surrounding loops, and it is called as a proud loop. Okay, then I am going to look at the narrowing of the terminal ileum, which actually opens like a slit by a spasm and fibrosis. Okay, so which will actually cause me formation of a strings sign. Okay, which is also called as the string sign of Cantor. Okay, which is also called as the string sign of Cantor. Okay, and then they open up a slit like, okay, you see here it is present down in the terminal ileum that I know already, and now they start to open and they become spasmed, and also because of the presence of fibrosis they start to appear like a thin string, okay, a thin thread, which is actually called as the string sign of Cantor. Since fistulae are present, especially between the ileum and the colon, okay, and also to the skin, vagina, and the urinary bladder, or the extra areas where the fistulas can be seen. Where anal fistulas are common, vaginal fistulas are common, okay, and urinary bladder fistula are common. So it is actually called as the vesico-urethral fistula, which is called as varico-urethral fistula, VUF. VUF, okay, vesico-urethral fistula, okay, which is also commonly seen in Crohn's disease patients. Now let's look at the radiographic sign, which is quite easy. Now you see here, this is the terminal ileum, okay, and then it is the colon. And in between them, you see here, there is a very, very thin line that is actually formed, which is actually called as the string sign of Cantor. Simple. right? Is it easy now? Yes, it is present down in the terminal ileum and it between the colon, and then it is going to cause the fibrosis, and also it is causing down the spasm of this area. So that's the reason it is looking down like a thin line, which is actually called as the string sign of Cantor. Okay, this is what it is in Crohn's disease, right? And you are also going to look at the same thing here. Okay, streaks of barium shadows are actually present down here when this is the barium follow through, and you see here multiple fistulas are entering. Okay, multiple fistulas, abnormal bowel dilated shadows, abnormal fistulas are actually coming down. Okay, and then connecting with each other. So this one is also again a characteristic feature of Crohn's disease. Multiple fistulas, streaks of barium, multiple fistulas and streaks of barium are the one that is actually causing the abnormal loop of the small bowel. Okay, abnormal loops of the small bowel. Okay, this is the string kind of Cantor, and all of them together is going to look down as a very peculiar radiographic feature, which is actually called as the apple core deformity. Okay, apple core sign. Okay, apple core deformity, we call it as. I will show you the picture so that you can actually understand. uh, this is a very classical picture, uh, always asked in so many, it is seen in so many textbooks. You see here, when you eat the apple, okay, in between you will be having a core. You see here at the part of the terminal ileum. Okay, in the image, in the part of the terminal ileum, I will be seeing down, it's just like the apple that has been bitten. So that is actually called as the apple core deformity. Either the string sign of Cantor can be seen or the apple core deformity can be seen. So there are two important radiographic findings. Yes, can everybody see the image? Okay, so it is the apple core deformity, which is a classical appearance of a radiographic feature in Crohn's disease. Okay, right. And then we are talking about, see, maybe let us say it's like this. Okay, since there is a lot of fistulas, okay, since there are a lot of fistulas that are present, which will be also fibrosing the neck, fibrosing granulomatous reaction, and they are going to narrow the lumen. So that's the reason it looks like an apple core deformity. Apple core lesions is also found in colon cancer. Okay, apple core deformities are also found in colon cancer as well, but particularly one of the most important reasons for colon cancer is Crohn's disease. Okay, so generally, I think you might have heard about this term. The people who smoke generally do not have this, antibodies. They actually have antibodies that is related down to the colon cancer or rectal cancer. So the people who smoke generally do not have the rectal cancer or colon cancer. Okay, so it's a simple thing, but it doesn't necessarily mean to say that you should smoke and so that you can prevent colon cancer or rectal cancer. No, it's not like that. But generally people who are smoking do not have the colon cancer. They are completely resistant to colon cancer. All right. uh, and then yes, we are going to see in the large bowel. Okay, colonoscopy or CT are the confirmatory diagnosis. Okay, and structures outside the colon are studied by the CT examination, and abdominal the pelvis with the oral or the rectal contrast. Okay, either barium follow through is going on or the rectal barium enema is going to go. And then diverticula are present. Okay, diverticulosis, the same like what we have seen in the esophagus diverticulum, according to the escape of the esophageal membrane to the Killian's dehiscence. This is also happening here itself, and it is forming up a small out bulging or a pouch like structure. And since they are involved and they are herniating and they are involving the submucosa of the intestine, in the muscular layer. So that's the reason they are actually called as the false diverticula. So diverticulosis is a condition where the colonic diverticula are seen, and they are the one that actually represent the herniation of the mucosa and the submucosa. So that's the reason they are actually called as the false diverticula. Okay, and they are multiple, and they can become inflamed, and they can bleed. So these diverticulosis is the most common cause of lower GI bleeding, and generally the right sided diverticula seems to bleed more than that of the left because of you know uh, frequent blood supply. Okay, I think this is something that has got to do with the mesenteric circulation, where the superior mesenteric vein is superior mesenteric artery is the one that is supplying the ascending colon, where the inferior mesenteric artery is the one that is supplying the descending colon. Yes, or do you want me to teach again the mesenteric plexus? You know about, we have learned about the celiac plexus, but we didn't learn about the mesenteric plexus. But I guess this is only mesenteric plexus consists of, abdominal aorta gets down and it comes down as the mesenteric plexus. The superior mesenteric artery goes down onto the right side, inferior mesenteric artery goes to the left side. Okay, and then once one part, that is actually superior mesenteric plexus, is going to divide down into the colonic branches and the appendiceal branches. Okay, and then it is going to divide down as the transverse colonic branches, and the descending colonic branches are arising from the inferior mesenteric artery. So that is whole mesenteric plexus is. Okay, let me give you, I think maybe you don't remember, mesenteric plexus. Okay, mesenteric plexus or mesenteric arteries. This is easy for us. Okay, yeah, look at it. Mesenteric plexus or mesenteric blood vessels. Mesenteric circulation, you call it as. Okay, this is a very, very famous picture. If you do not know, maybe you have to, completely go back and try to remember this thing once again. Sorry, just wait. Okay, mesenteric plexus. Superior mesenteric artery, inferior mesenteric artery. The same way are the arterial blood vessels as well. Okay, anastomosis, same arterial blood vessel. Okay, you need to learn about the branches, and the bleeding actually depends upon those branches. Okay, and even the veins also form the same thing here. Okay, veins also form the same kind of mechanism, same kind of distribution, right? Those are the branches names. Like there are something around like 6 branches that is related down to the mesenteric anastomosis. Okay, mesenteric artery, mesenteric vein, all this one. Okay, this complete thing is actually going to form out 6 branches. Better maybe if you have time, better get back, when you get back home, maybe try to learn it in your anatomical textbook. Sorry, why can't I open this image? Recall. Mhm. Just give me a second. Maybe I can take a screenshot. Okay. Right. So the bleeding actually is coming down from the mesenteric plexus, mesenteric anastomosis here. Okay, all the mesenteric arteries, inferior mesenteric artery, superior mesenteric artery, inferior mesenteric vein, superior mesenteric vein are the ones that are supplying, is actually the ones that are actually causing a lot of bleeding in diverticulosis patients. Okay, so I think right, right. Then we are going to diverticulitis. Okay, you can see here there are smaller in this image, there are smaller polyps that are coming out. You see smaller out pouchings that are seen. So that's the reason I can actually understand that I'm looking at a diverticulosis patients. Okay, a diverticulosis, that's it. It is a very simple diagnosis. Okay, it's not difficult, it will be just only image based. So CT is the modality of the diagnosis, and pericolonic soft tissues can be visualized on the CT, which is generally impossible to do it on the perian enema. So gold standard test for diverticulitis is CT scan. Remember it that way. Okay. And then what is the CT findings? CT findings will be the presence of the diverticula and include the thickening of the adjacent colonic wall greater than 4 centimeters. Okay. Uh, that is the radiographic feature here. Pericolonic inflammation is the hazy areas which are present, and streaky disorganized amorphic densities or the fat creeping side is again seen. Abscesses can be formed and the perforation of the colon can be happening. So all this one, diverticulitis, Crohn's disease are interrelated. Okay, so that's the reason you actually have to learn about this one. Okay, right. And then you see here, so hazy densities that is present down in the peri-inflammatic flat. You see, this is the fat creeping here. Okay, this is the fat stranding or the fat creeping sign. Okay, and then focal infiltration is always present. This is the focal infiltration. Okay, you can see the increased fibrosis of the intestine here. Increased density along the intestine, and you can also see that this is the fat stranding. Increase in the attenuation of the fatty areas of the intestine is actually called as fat stranding. Okay, so which is actually indicating that I am looking at an inflammatory condition. Okay, right. And the same thing you see here, there is a large infiltration here and edematic fluid that is present around this place, which is represented by the hypodensities. Okay, and then we are looking at the attenuation here. Okay, and infiltration of the normal fat. So this is all the fatty infiltration that is seen here. Okay, so this can be happening because of the perforation that can be happening because of the formation of the diverticulitis. Okay, a presence of a diverticulum here. Okay, presence of a diverticulum and the abscess is formed, and so that's the reason I'm looking at the surrounding edema and inflammatory changes along with the fat creepings. Okay, that's it. So that's it. Then polyps are also same like diverticula itself, but polyps are actually, when we are looking at the ulcerative colitis, I was saying that these patients actually present up with pseudopolyps, right? So these pseudopolyps, guys, what actually see is that the patients with polyposis syndrome, okay, polyposis syndrome in the sense, obviously I'm talking about adenomatosis polyposis, okay, which is also called as MAP, multiple adenomatous polyposis, multiple adenomatosis, adenomat adenomatosis polyposis. Okay, adenomatosis polyposis or MAP, okay, or polypoid syndrome, which has got developing in colonic malignancy. And I'm not going to get this one. These are malignant. That is what you have to remember. And they are hyperplastic polyps. That is what you remember. The hyperplastic polyps are seen in colonic polyposis or multiple adenomatous polyposis disease. That is how you actually remember. Okay. and they are visualized on colonography and barium enema. Okay, I think you need not technically learn about this one because this is quite advanced one. You can see a polyp formation. Okay, this is a virtual endoscopic CT, VECT. Okay, virtual endoscopic CT. The CT scan that is done as an endoscopic study without inserting the endoscope. So that is actually called as VCT. Okay, so this one is actually called as a polyposis disease. So that's how you remember this one. Okay, maybe it can be asked down as an image. Okay, and then call it colonic polyps. I think I'm not going to let us skip off this content. This is all maybe a large thing for us here. Colon cancer. Okay, yeah, this one maybe. Yeah, polyps. Maybe let us keep off that content here. And last one, final part of the chapter. I'm going to take 10 more minutes, and then we are done with the whole GI system. Okay. See, colon cancer is the one that is actually happening as the, a malignant cancer that is seen down in the large intestine. Okay, it is seen down as the large intestine. Colonic carcinoma. The imaging findings of the colonic carcinoma include the presence of persistent, large, polypoid filling defects, okay, and annular constriction of the colonic lumen, okay, constriction or narrowing of the colonic lumen, which is actually producing a defect that is called as the apple core deformity. Okay, apple core lesion or apple core deformity or apple core appearance all is a very classic finding of colonic carcinoma, and this one actually causes the microperforation and manifest by the infiltration of the pericolonic fat with streaky or hazy densities of increased attenuation with or without presence of extraluminal air. Simple thing to understand. Okay, there is a large polyp, okay, that is filling up the lumen of the colon, which is cancerous in nature, and two of them coming together is actually narrowing that lumen, which is looking down as an apple core lesion, which I showed in the picture. And then microperforations actually happen by the infiltration, so there will be pericolonic fat stranding, okay, or streaky haziness that is increased densities along the fatty regions of the colon, and there will be presence of an extraluminal air. So that is what the diagnostic features of colon cancer are. You see here, this is the apple core deformity, a very classical appearance. Okay, same like thing. So there are two polyps that are present down here, and they are narrowing down the lumen. Simple. It is for the circumferential growth of a colonic carcinoma. So that is what it is, the apple core deformity, which is the classical, and the lesions that are actually, extend, okay, extend as the overhanging edges. So there will be extended edges on the top and on the bottom, okay, and in the between it is the narrowing that is seen, and barium is passing through this narrow lumen. So that's the reason it actually forms out a lesion that is actually called as apple core deformity. So remember it that way. You need not explain it. Okay, you will not be asked technically a question about from this one, but it can be asked down as an MCQ, given down this image and say that, okay, recognize this structure, what is this structure and what is this disease. Okay, that's it. So this is the apple core deformity, I think. Then you will be seeing, okay, and on the large bowel obstruction also in the what do you say, in the barium studies, what we are actually seeing is that, okay, you are seeing abnormally dilated bowel loops, okay, abnormally dilated large bowel loops, and with the small bowel loops completely consisting of uh, material here. So this one actually shows that you can also sometimes use contrast material barium along with the CT scan, and then you are actually going to look at the large bowel obstructions, something like this. How can I actually find it out? I can actually find it out. Abnormally dilated bowel lumens on the right side. So that's it. That's what the simple radiographic feature is. Okay. And then abdominal mass. Okay. Abdominal mass is the one that is actually compressing, and so that's the reason there is the large bowel that is actually dilated. Okay. And this is a contrast study because I can see the iliac arteries enhanced here. Okay. And there is an enhancement. Okay. So this is a large abdominal mass. Okay. Soft tissue mass. Okay. Carcinoma, it is actually carcinoma of the sigmoid colon. Okay. Right. Colitis, ulcerative colitis, granulomatous. I think I told you already, taught about this. It is actually forming the P-ANCA antibodies, right? And similarly appear radiographically, but clinically of different. Okay, they appear the same many forms on radiology. CT findings, I told you, like it is actually going to form a thumb printing sign. Okay, like I said, thumb printing sign is a characteristic feature of ulcerative colitis. But there is also another appearance. Okay, this is the thumb printing signs. Okay, thumb printing signs. See, it is appearing down as the thumb print. Okay, as a white thumbprint that is put down on an intestine. So that is the thing. It is actually called as thumb printing sign. You see here, this one. So this is the thumb printing sign. Okay, and these are the one that is actually caused by the toxic megacolon, Clostridium difficile, which is also called as the pseudomembranous colitis. Okay, if it is happening because of Clostridium difficile, you call it as pseudomembranous colitis. Or if it is happening because of a genetic condition, you call it as ulcerative colitis. Simple, right? And then I'll show you one picture. Then we are done. We will go lead pipe appearance. Okay. Mm, yeah, this is the very classical image. Okay. Here, see at this image. Lead pipe appearance. In this image, what we are actually looking at, did you get the image? Yes, see, this one is a classical picture. That one is actually showing up the barium that is actually filling up the contrast material in all over the colon, and it is completely spasmed, and it is looking down as a long tube, a decompressed long tube. So that one is actually called as a lead pipe appearance, which is again a characteristic feature of colitis. Okay, it can also be seen in toxic megacolon. Toxic megacolon generally is showing up as a thumb printing sign. Okay, it can also be seen in ulcerative colitis as well, but classical feature is this one is much more, that is actually called as ulcerative colitis, which is a lead pipe appearance. Okay, so I think we are done here. Appendicitis, maybe simple. Appendicitis, you know, I have already been talking about appendicitis a lot. It is the inflammation of the appendix, and the main important diagnosis is actually made by clinical diagnosis itself, clinical observation itself. And you are going to learn about two clinical diagnostic scores, which is actually called as the Alvarado score and the appendicitis inflammatory response score. Okay, clinical diagnosis is important in appendicitis, which will be accompanied by the right iliac fossa pain and also accompanied by fever, low grade fever, along with vomitings. Okay, that is what appendicitis is all about. Okay, McBurney's point, tenderness, yes, that is fine, right? But once you have made a suspicion of appendicitis, what we are going to do is that we are going to prescribe either an CT scan or ultrasound or an MRI. But right now, in the modern times, okay, CT scan along with the contrast study is the gold standard for recognizing the appendicitis. Okay, and if the stones are formed within the appendix, it is actually called as an appendicolith. Okay, if the stones are present in the appendicular lumen, it is actually called as appendicolith. Okay, which is again a characteristic feature. Appendicitis can be classified as simple appendicitis and complicated appendicitis. Sorry, uncomplicated appendicitis, simple appendicitis, or uncomplicated appendicitis, or you can call it as suppurative appendicitis or gangrenous appendicitis, or called as complicated appendicitis. Okay, there are two types of appendicitis: simple appendicitis or uncomplicated appendicitis, or the next one, the second type is complicated appendicitis, which has two categories, which is suppurative or granulomatous types of appendicitis. Okay, and appendicolith is a characteristic feature of, okay, appendicolith is a characteristic feature of appendicitis. Okay, and then the CT findings, as simple as pancreatitis itself, you will be seeing enlarged appendix. Okay, you will be seeing enlarged appendix, which is greater than 6 mm. Okay, and the appendicular wall is also thickened, first thing. Then you can be actually seeing there is a surrounding increased density in the fat, second radiographic finding. And then you are also going to see at the right lower quadrant bowel dilatation. Okay, that is what I told you this morning also. So that is the third radiographic finding. All of them together is going to tell you that I might be looking at a case of acute appendicitis. You see here, this is the appendix I'm looking at, and see this, the layer of the appendix that has been enlarged. Okay, and then I can see the haziness that is present down along this area, along the mesenteric fat. Okay, anywhere haziness along the fat in the abdomen is can be called as the fat stranding sign. Anywhere inflammation, it is called as the fat stranding sign. And then you can see here focal infiltration of the fat is present. Okay, uh, you see, okay, right, most of the common bacteria that is causing appendicitis, suppurative appendicitis, is Pseudomonas aeruginosa. Okay, Pseudomonas, Pseudomonas are the one that is actually causing the bacterial appendicitis. Okay, E. coli is also there, Pseudomonas is also there. Okay, right, E. coli is the most common one. Pseudomonas also causes appendicitis, which is granulomatous in nature. And maybe this is an interesting question: a parasite that causes appendicitis. Okay, I think you will be asked something like that: parasiting causing appendicitis. Any idea? I think African guys has to answer this question: parasite causing appendicitis. Any idea? It is very famous in Africa, this condition. Yes, normally the appendix does not harbor microbes. Yes, so that's the reason you are calling it as simple inflammation. So that's the reason it is called as simple appendicitis. Okay, but over time, when the inflammation continues and continues, you call it as suppurative appendicitis, because as the fecal matter starts filling up the appendix, inflammation increases. Okay, and then they will be developing bacteria in it, generally E. coli or Pseudomonas. Okay, so that is one is actually called as complicated appendicitis or suppurative appendicitis. Okay, Benedict, can you answer this question? What is the parasite? African guys, if you are present, what is the parasite that actually causes appendicitis? Okay, Indian guys, try it. Okay. Okay, remember it is cystosoma. Ascaris lumbricoides, schistosomiasis, All of them are actually causing appendicitis. Ascaris lumbricoides, schistosomiasis are the one that are actually causing Schistosoma japonicum. Okay, remember, Schistosoma japonicum is present in the world only in China right now and vastly present down in Yunnan province, especially in Dali. Okay, remember, right now the world completely has eradicated Schistosoma japonicum. Remember, Schistosoma japonicum has been completely eradicated from the world, but right now it is present down only in China, especially in the Yunnan province that is quite famous in Dali regions. But in Africa, you are going to find out Schistosoma hematobium or urolyticum, where the urinary bladder schistosomiasis or the appendix schistosomiasis is quite famous. Okay, right? Schistosoma japonicum. I think you heard these names. Schistosoma japonicum, japonicum, okay, in China right now, okay, right, and schistosoma hematobium, or schistosoma urolyticum. Urolyticum is present down in Africa and Brazil. Africa and Brazil. Okay, so that are the ones that are actually causing, kidney disorders and the patients with the liver conditions and along with appendicitis. Okay, it is actually related down to the mesenteric circulation. Maybe okay, interested guys can read out this part, and then just give me a minute. Here. Okay, right. Okay, maybe if you want to learn more about appendicitis and its diagnostic feature, okay, you can actually look at this paper. Okay, it's an interesting paper. You can know how the diagnosis of appendicitis and all other research stuff and what are the radiographic findings, everything will be are actually given in this one. Okay, you can, if you have time, maybe you can read it. Okay, then the last thing here I can say here is what are we talking about? Schistosomiasis and Ascaris lumbricoides. Then that is actually we are going to find here. I think that is perforations are most common in appendicitis patients. Okay, appendicolith. You can see here. This is an image-based question. Remember this image. Okay, appendix, dilated appendix, and there is an stone that is present in the lumen of the appendix. So this is actually called as an appendicolith. So that's it. Nothing else. Appendicitis is a very simple diagnosis. Okay, abnormal dilatation of the appendix, enlargement appendix, and periappendicular fat stranding. Okay, that is what that present. Perforation can be present. If perforation is present, you can see air along the regions. Okay, you can see air. Okay, here there is no perforation one, but the here if the calcification is present in that one, you can see here, this is the perforation, a small air that is present down here, which can also uh, show up as the air that is present here. Okay, perforation sign, extraluminal air we call it as, fat stranding is there, appendicolith is present. Okay, all of them is actually the characteristic features of appendicitis. Then there are two important signs you have to remember. Arrowhead sign. Okay, arrowhead sign is a character, and cecal bar sign. Remember the names, that's it. Not, don't go for the radiology. Okay, is appendicitis. Okay, arrowhead sign and cecal bar sign is a characteristic feature of appendicitis on contrast studies. Okay, just write the names. Don't worry about its definitions. You will not learn about that one, but they are asked as questions. arrowhead sign and cecal bar sign are characteristic features of appendicitis on contrast studies. Okay, a hyperdensity that is present within the lumen of the appendix is called as appendicolith. Extraluminal air that is seen in the right lower quadrant can be happening because of a perforated appendix. Okay, and maybe this small image, because I don't want you to leave the clinical questions which is coming down in the examinations. So that's why. Uh, just wait. Okay. Copy image. Okay. May this one remember last most common finding. Okay. Most common position of the appendix causing appendicitis is retrocecal position. Okay. Most common position of the appendix causing appendicitis is retrocecal in position. Okay, right? And the least common is the pre-ileal. Okay, pre-ileal or the post-ileal. Generally, it is pre-ileal. Sorry, post-ileal is the one that is actually causing the least position. Okay, positions of the appendix is a very important question. Okay, which one is the most common position, which one is the least common position? Generally they ask this question. Okay, so retrocecal position appendix is the most common one. Okay, right, and post ileal is the one that is least common. That's it. That is what you have to remember about appendicitis, nothing else. Okay, positions, different positions, 2 o'clock position, 4 o'clock positions, but I'm not going to talk it that way here. Remember, retrocecal is the most common position of the appendix, and post-ileal is the most common, least common positions of the appendix. And high positioned appendix, low positioned appendix is also one of the important location. Okay, high abdominal and low abdominal appendix is also present. That's it. But you need not worry about all those conditions. So I think that's it. We are done for the day. So we completed the whole abdominal system. I'm not going to talk about urogenital system until you guys read about this. Okay, complete the whole abdomen. Okay, there is only one disease you need to learn in urogenital system, which is actually the urolithiasis, kidney stones. Other than that, you don't learn any conditions there. Okay. Uh, Next time I'm going to find some time and I'm going to teach that one. So next week when we are coming, we are going to learn about the musculoskeletal system. We're going to start with musculoskeletal system. Okay, it will musculoskeletal system generally takes around like 1.5 week, maybe 3 days to 4 days. It will take to complete the musculoskeletal system, and then we will have central nervous system, which will take again 1 week of time. So mostly in another two weeks, yeah, we will be completing up radiology syllabus. Okay, 2 to 3 weeks, mostly next 3 weeks. By end of this month, okay, within the next coming 15 days, I will try to complete off radiology, complete for you. All right. So gastrointestinal system is a very important chapter. There will be a lot of essay questions, lot of MCQs, lot of 2 marks, 4 marks, fill in the blanks, everything. You can't leave anything from here. Okay, you have to study and study. Most important essay questions are be coming from the large bowel obstruction, small bowel obstruction, pancreatitis, and appendicitis. Okay. Other than that, don't worry. But esophageal carcinomas, all other things will be asked down as 1 mark questions. 4 mark questions you will be asked down with ulcers, peptic ulcer disease, and other things. Okay, I will post out the important questions in the group later on so that you can actually refer back. Okay, so any doubts in the whole abdomen? And sorry for you guys to keep you waiting. Okay, I have taken a lot of time of yours today. It is actually your resting time now, but still I would have to complete, so that's the reason I took time. Okay, thanks for your patience. Right? Any difficulty? Right? So please keep on studying. Okay, I will also transfer the urogenital system. Okay, maybe some of the, what do you say, for your overall looking. You just give it a look, because you see here that the other urogenital systems theory classes has got only something around like 16 slides, I guess, right? 16 slides or 20 slides. So that's the reason it is not really very important. The only thing that you will be learning is about only kidney stones there. Okay, right? So I will transfer the urogenital system PPT also. You can try to read. But in the theory, it is present down in the rain classroom. So just give it a read. It is just 16 slides. So if you do not understand, then maybe remind me last time. I can actually teach you there in the next session. But if you understood it, of 16 slides, if you understood it, okay, just try to remember that way itself. If not, that is not necessary. Okay, urolithiasis, only one question will be coming, only one question you will be asked from kidney diseases. So try to learn it. It's not big chapter, it is just only 16 slides or 20 slides are present in that chapter. Okay, here, but for your information purposes, but for reading purposes, I'm going to transfer the practical slides to you. Read it later when you have time. Okay, just for your interest. I will not be asking a lot of questions from this one. Very few questions which are present on the theory slides will be asked itself. But urogenital practical for your knowledge purpose, yes, you can read it by yourself. Okay. Yeah, only if necessary, if time permits, yes, we will talk about this one. If not, I will be talking only about urolithiasis. Okay, all anatomy same like the way we are doing for every system. A detailed diagnosis of all diseases of urogenital system in radiology is there. So except for urolithiasis, urogenital system generally do not have any important questions. Corticorenal cyst, kidney stones, and then bladder cancer. Only three very small diseases that you have to learn here. Other than that, nothing else is important. No questions from anatomy and other things. Okay. Right. So I think that's it. If you have any doubt, give it a read. Any doubts, you just message me so that I can take time, maybe something like half an hour next time, so that I can complete urogenital system. If not, if you have understood it, I will not teach. I will just directly go to the musculoskeletal system. So have a nice time.